哎，你好，这个工作人员在线上吗？
你好，李主任，没听到声音啊？
哎，
哎，李主任，
哎哎，
哎，我们那个马上就准备开始了，魏主任，哎，好，
嗯，好嘞，好嘞，哎，
好嘞，好嘞，好嘞，哎，好。
尊敬的张英哲院士、李维石教授、陈伯来教授、马学晓教授、孙垂国教授、王鑫教授，以及来自世界各地的各位专家同道，大家上午好。Dear Admission 张英哲 Professor 李维石 Professor 陈伯来 Professor 马学晓 Professor 孙垂国 Professor Wang Xin and all the experts and colleagues from all over the world. Good morning, everyone. Welcome to the 5th EndoSurg International Training Week on Spinal Endoscopic Techniques. I'm Dr. Zhou from the Department of the Spine Surgery. On behalf of our hospital, I would like to extend a warm welcome and a sincere thanks to all the guests. First of all, we would like to invite Professor Ma Xuexiao, co-chairman of this training course and vice president of orthopedic department, the affiliate hospital of Tsinghua University, to give a review and an introduction of the training program. Welcome, Professor Ma Xuexiao. Welcome.
Good morning, academician Zhang Yingzi and Professor Li Weishi, Chen Bolai, Sun Chuiguo, Xin, and all the respected visitors. Welcome to Qingdao to attend 5th International Training Course on EndoSurg Technique. This training course was sponsored by the 3 hospitals, the Beijing University 3rd Hospital, the Guangdong Provincial Hospital of Chinese Medicine, and the affiliated hospital of Tsinghua University. On behalf of the 3 sponsors, I'd like to review the whole process of the training course in the past 3 years. This training course will concentrate on a new surgical technique, which is called EndoSurg, and a new instruments. The name is Unitec Plus endoscopic system. The Unitec system seems upgraded from the young and teeth, but is quite different, especially on concept and philosophy. The Unitec endoscopic system can provide the large endoscopic view and visualized bone resection, and the endoscopic the channel permits the strengthened instrument put in to do a lot of complicated cases. Instruments and technique can be used to treat complicated spinal diseases, including all kinds of disc herniation, most of the lumbar stenosis, 1 to 2 degrees spondylo, and some degenerative scoliosis without unbalance. The instrument was designed and produced in 2018 by Chinese surgeons and engineers. And the first surgery was performed in China in 2019, and then popularized all over the world. The UNITEC system got CE certificate in 2021 and appeared in the annual conference of EuroSpine and attract attention of the European people. They cannot believe the TLIF can be done assisted by the endoscopy. What's wrong? So in November 2021, we hold a live EndoSurg surgery done from Qingdao to transmit all over the world to let the surgeons who love endoscopy to know about in detail about this the concept and the philosophy. And at that time, 39 participants joined the live surgery and to communicate online to talk about this technique. They are excited and interested in the new concept guided endoscopic surgery. In order to to talk about this technique in detail and face-to-face, a group of 3 persons was invited to visit Europe, and Dr. Zhou Chuanli and Xu Derong and I, a 3-person group, fly to Europe to walk around 3 countries to talk about this technique as face-to-face. We participate in EndoSurg conference and visited Switzerland, Spain, and Germany. The most important thing during this trip that we established the UNITEC Global Training Center in Düsseldorf of Germany. At the same time, we host the first international training course in Düsseldorf, Germany. And 20 participants from 7 countries joined this training course. When we back from Europe, we start the training course held in China. The training course was held in Qingdao University, right here, in May 2023, face to the Asian visitors. The second training course in China was held in July 2023, face to the the visitors of the European and Asian from Germany, Spain, Malaysia, and Hong Kong area. The third one was held in March 2024. This is the biggest one in the history of the training course international, and around 40 participants joined this training course, and over 750,000 surgeons witnessed online. And the fourth one was held in Guangdong province and hosted by the Guangdong Provincial Hospital of Chinese Medicine in April 2024. In addition, the training course held in China, another 3 courses was held in Germany. The first one I just introduced to you. The second one is hosted by the Sun Chuiguo professor. He hosted the second one in Germany, and 20 participants from Germany, France, the United Kingdom, Spain, South Africa, Portugal, and Poland joined this training course and give him a high praise of the technique. The third one is hosted by this group, is held in March 2024. The Professor Xu Derong and I fly to Germany, and Professor Zhou Chuanli give a live surgery from Qingdao, China, to the training course. In addition to the training course hosted by 3 sponsors hospital, there are other many international training courses held by other countries. All of them are the volunteer of the EndoSurg, the endoscopic technique. The first one is held by the Malaysia, which is held in September of 2023. Professor Sun Chuiguo was invited by the Malaysian Society of Spinal Endoscopic Surgery to give a lecture and guide the cadaver practice and a surgery. The next one is held by Hong Kong, and the team of Guangdong Provincial Hospital and Qingdao University was invited by Neurological Society of Hong Kong. The next one is France. The Professor Li Yingjing from Guangdong fly to France, which was held by the EndoSurg. The 25 participants from France, Germany, Italy, Spain, and Singapore attend this training course. The fourth one is in Switzerland. Dr. Fasha sponsored the EndoSurg Academy. I am honored to be invited to be one of the 9 sponsors to establish the EndoSurg Academy and hosted the training course. Now today, we are going with the international training course. Welcome all of the visitors. We will stay in Qingdao for at least 5 days to process our training course. Hope everybody can learn a lot of it. Thank you very much.
Thank you, Prof. Mark, for the review of the exciting history about this international training course. We are so happy, and we trust this week will also be very successful. Next, we will welcome co-chairman of the course, Professor Chen Bolai, also the vice president of the hospital of Guangdong Province Hospital of Chinese Medicine. Welcome, Professor Chen.
Good morning, everyone. Respected colleagues and good friends, we have come afar. I'm Chen Bolai, come from Guangdong Province Hospital in Guangzhou of Chinese medicine. Welcome to beautiful Qingdao City. It's my pleasure to chairman to welcome everyone attending the 5th edition of the EndoSurg Spine Endoscopy International Training Course. We know with the flourishing development of minimal invasive spine technology in China in 2018, a lot of Chinese business collaborated, include Ma Xuexiao, Sun Chuiguo Professor, developed a new generation of endosurgery technology based on the classic ENSYS and TSYS system technology. Today, we are honored to welcome 18 experts from Spain, Peru, Portugal, and Malaysia to participate this training course this week. We hope that everyone will gain a deeper understanding of the endosurgery techniques during this training course. And I hope that all of you will carry out more spine endoscopy surgeries so that more and more patients can enjoy the benefits of minimal invasive spine surgery. We also hope that we will be more opportunities in the future to deepen cooperations with you and jointly promote the international development of spinal surgery, spinal endoscopy surgery. And last, I wish you all a wonderful time during your stay in beautiful city, city Qingdao. And I look forward for waiting for you in Guangzhou, in 这个青岛 Happy Technics Day, Teachers Day, and Middle Autumn Festival is our Chinese the happy day. Thank you.
Thanks, Professor Chen. His team is a very, very powerful team. Also, Professor Liu Yongjin is from his Guangdong hospital. Yes, they are very, very, several colleagues, they're very famous in minimally invasive surgery in China. So next, we would like to invite co-chairman of the training course, Professor Li Weishi. He is also director of the orthopedic department of Peking University State Hospital. Because of some other business, Professor Li will deliver a speech online. 威斯教授，您在线上吗？
我在。
您可以开始，谢谢。
好。Dear Professor Ying Zhejiang and dear Professor Xue Xiaoma and Bolai Chen, and all the colleagues, especially all the international colleagues, welcome to Qingdao to attend the 5th EndoSurg International Training Week. I believe it's a very important training course nowadays, because during the past several years, the endoscopic technique had developed very fast, especially in China. Right now in China, almost every big hospital, especially in the big city, the hospital, the orthopedic surgeon can use endoscopic technique to treat the patients. So right now, this technique is very popular. I believe it's a good opportunity for all to learn this new technique. And welcome to China, and welcome to attend this training week. I want to thank Dr. Xue Xiaoma for your excellent organization of this course. It's very sorry that I cannot go to Qingdao, but I believe in this week, everyone can learn a lot. We can communicate each other. I also send my 2 colleagues, Dr. Sun and Dr. Jiang, to attend this meeting. They will give you a speech and give you some cadaver show, I think. I I believe you can learn a lot from this course, and I also hope you will go back to your department and can use this new technique to treat your patients in the near future. And I hope everyone will have a good time in Qingdao. Thank you. Thank you so much.
Thank Professor Li. His department is very famous in open spine surgery, even now in minimal invasive spine surgery. Professor Xun Chui also his colleagues. Next, please warmly welcome academician Zhang Yingzhe. He is the chairman of the orthopedic branch of the Chinese Medical Association and chairman of the orthopedic branch of the Chinese Medical Doctors Association. Also, he will give his speech online. Welcome, Zhang Yingzhe, Professor Zhang Yingzhe. 张院士，您在线上吗？
在呢，在呢。
好的，您可以开始了，张院士。
好，
谢谢。
尊敬的陈伯来院长、马学校主任教授，尊敬的各位专家、各位授课老师，尊敬的来自全球各地的骨科的同道，大家上午好。今天我们隆重举办第5期EndoSurg脊柱内镜技术国际培训班。首先，我代表中华医学会骨科分会，代表中国医师协会骨科分会，向国内及其远道而来的各位国际的友人表示热烈的欢迎和诚挚的问候。同时，我也作为清大附院骨科医院的院长，这个东道主，感谢大家对清大附院多年来的支持、关心、帮助和厚爱。近年来，内镜技术已经发展成为脊柱外科手术体系的重要的集群之一。中国脊柱内镜专家在内镜的设备的研发和技术创新等方面进行了广泛而深入的探索，取得了一系列成果。清大附院脊柱外科与时俱进，我们在胡有谷等老一辈打下的良好的基础之上，我们年轻的中年的骨科医生也不断的传承创新。以马学校教授为代表的中生代瞄准脊柱了微创技术，尤其脊柱内镜技术，他们10年磨一剑，在国内众多专家学者的鼎力支持下，主持了国家重点研发计划等一系列高水平的项目，获得了山东省科技进步的1等奖、2等奖，打造了亚太脊柱内镜技术的交流中心，国家卫健委专项能力培训基地等学术的平台。去年脊柱外科团队受商务部直属中国欧洲经济技术合作协会的委派，到欧洲进行了脊柱内镜专题的学术交流，成功举办了首届境外的培训班，进一步缔结了与欧洲脊柱外科同道的深厚友谊和学术交流。今天我们又迎来了20多位有着共同理念与追求的海内外同仁，希望通过为期1周的交流与培训，进一步汇聚各位专家的聪明才智，深入领略探讨技术的精髓，为脊柱内镜技术的国际传播与合作开启新的篇章。最后，预祝这次学习班 圆满成功，也祝海内外的各位专家在青岛身体健康，学习顺利，并留下美好的回忆。谢谢大家。
谢谢院士。We are grateful to academician Zhang Yingze for his attentive word and affectionate blessing. In China, we have this culture. We should let our leader, our big boss, to give us support for this international cause. Yes. We trust and the leadership of the orthopedic pioneer represented by academician Zhang, the development of minimal invasive spine surgery in China and even in the world will surely enter into a new stage. Next section, we should have a group photo. First, we should sit here. Then we'll go outside. Then we back for the other things.
Mm. Mm. 你好啊，你很会很客气，你的朋友，我知道你知道吧？
不说了，不说了。那个V10教授的那个照片还能看，还能露出来吗？啊，不，他那个视频还能拿出来吗？Okay. Next, I want to introduce the tutor for this international training course. First one, Professor Li Weishi also have just give us his speech. Also from the Peking University Third Hospital. Another one, Professor Ma Xuexiao, also the chairman of this course from the affiliate hospital of Qingdao University. Third one is Professor Bolai Chen, also a co-chairman of this course, also from the Guangdong Hospital of Chinese Medicine. The fourth one, Professor Sun Chuiguo, also the colleague of Professor Li Weishi, also from the Peking University Third Hospital. The fifth one, that's me. I'm also the colleague of Professor Ma Xuexiao. The sixth one, Professor Wang Xin, is also from the first hospital of Lanzhou University, very far away from here. Also, Dr. Xu Derong is our colleague of the Philippine Hospital of Qingdao University. Also, there are 4 faculties will come here in the next few days. First one is Professor Jiang Yi. He is from the Beijing Haidian Hospital. Another one, Professor Jiang Jile, also from the Beijing Jishuitan Hospital. The third one is Li Yongpeng. He is a colleague of Professor Chen Bolai, also from Guangdong Hospital of Chinese Medicine. Last one is Jiang Sui. Jiang Sui is also a colleague of Professor Sun Chuiguo. Let's welcome for their support for this international course. Welcome, everyone. The next section is very we should exciting for the next section. We should know each other from then on. That's self-introduction. Everyone should have your photo. You will stand and give us a self-introduction for you, from you. Thank you.
I can speak Mandarin fluently, no problems. Actually, I'm a neurosurgeon. I'm actually glad to be honored to be able to join this conference. Thanks for that.
Hello, good morning, everyone. I'm Fazli, and I'm from Malaysia also. And I'm actually a orthopedic surgeon. Actually, it's not neurosurgeon. Okay, I'm an orthopedic surgeon. Right. Thank you for inviting me to and proudly to be here with you all. Thank you.
Hi, good morning. My name is Lin Fonseca. I'm a neurosurgeon from Lisbon, Portugal, and I want to thank the opportunity to learn with you. Thank you.
Hello, everyone. I'm Luis Cardoso. I'm a neurosurgeon from Portugal, from a small city is Évora, and I'm grateful to be with you.
Hello, my name is Ricardo. I'm also from Portugal, Lisbon. I'm a neurosurgeon, and it's a pleasure to be here with you.
Good morning, everybody. I'm Angela. I'm from Madrid. I'm a neurosurgeon. I'm really happy for being here. Thank you very much.
Good morning, Rebecca Conde from Valencia, Spain, and thank you for the opportunity for this course. Thank you.
Good morning, everybody. My name is Augusto Covaro. I'm orthopedic surgeon from Barcelona. Thank you for inviting me to this course.
Good morning, everybody. My name is Pablo. I'm a neurosurgeon from Madrid, and thank you for this great experience.
My name is Alberto. I came from Santiago de Compostela, north of Spain. I'm very grateful for being here. Thanks.
Good morning, I'm Ángel Escámez. I'm an orthopedic surgeon from Murcia, in south of Spain. I'm very glad to be here and thank you for the invitation to this course.
Good morning. My name is Rubén Hernández from Valladolid in Spain. I'm an orthopedic surgeon and I'm really happy to be here for this week. Thank you.
Hello, good morning, everybody. My name is Manuel Pineda. I'm a neurosurgeon from Badajoz, a small city in Spain, and I'm very grateful for this great opportunity to visit this great country. Thank you.
Hello, my name is Manuel Rollano. I'm a neurosurgeon in Badajoz, in Spain, and I work too in Évora, in Portugal, and it's a pleasure for me to be here with you all this week.
Good morning, my name is Fernando Ruiz, neurosurgeon from Madrid, Spain, and very honored to be here with you. Thank you.
Hello, everyone. I'm Jorge Tirado from Seville in Spain, and I'm so glad of being here to learn from you. Thank you so much.
Good morning. My name is Alberto Rondin. I'm from Madrid, Spain. Thank you for the invitation.
Okay, thank you, everyone. Welcome all the participants from different countries. Next session, we would like to invite Dr. Xu Darong to introduce the next program of this course.
Okay, hello everyone. I'm Dr. Xu from the affiliate hospital of Qingdao University. Now let me introduce the training program for you. In general, on the first day, the second day, and the fourth day, we will give the lectures and get into the operating room to watch the operations. On Wednesday and Friday, we can have the chance to practice on cadaver in the workshop. Today, we have 3 operations, including the transforaminal approach, interlaminar approach, and the endo-TLIF by our team. Tomorrow, Professor Jiang Yi and Wang Xin will give the lecture about endolab surgical procedure and EndoSurg concept, a complication on lateral lumbar spine surgery. Also, we have prepared 3 operations, including posterior surgery, lateral surgery, and endo-ULBDD. On Wednesday, we will take practice on cadaver for the lab surgery visitation and hands-on workshop, since there are limitations of visitor in the operation room, and also for a better experience on the specimen. All the participants are divided into 3 groups. Please remember which is your group because it is very important for you. We also have printed copies. If you forget it, you can check the document. On Tuesday, Professor Jiang Shuai will share his tips and tricks for visualizing reamers and burrs. Professor Lin Yongpeng will give a report about a standard procedure for posterior cervical spine surgery. At the same time, we have prepared 3 operations to perform. On Friday, we go on practice on cadaver, and you can get your certificate of training on closing ceremony. For any question during the event, you could contact me and Mr. Zhang at my number or by WeChat, or you could contact Sophia by WhatsApp. I wish you enjoy your stay in Qingdao with us together and you can get what you want here. Thank you very much.
Thanks, Dr. Xu. We should end the welcome ceremony and we should start the lecture. So we invite Professor Sun Chuiguo to moderate the other lecture. Professor Sun Chuiguo.
Okay, let's go on our topics. And I am Dr. Sun from Peking University Third Hospital. I'm very happy to meet you here. And next, let's welcome the chairman of our department, our orthopedic department of Peking University Third Hospital, Dr. Li Weishi. Li. Welcome Dr. Li to give us his presentation about the history, current status, and the future of spinal endoscopy. Welcome.
Can you see the PPT?
Yes, very clear.
Good morning, everyone. It's my pleasure to attend this training week. Just now, I said it's very sorry that I cannot go to Qingdao, but I would like to give this lecture about the technique evolution of endoscopic spine surgery. I come from Peking University Third Hospital. First of all, I would like to introduce my department in brief. My department is belong to the Peking University Third Hospital in Beijing. Beijing is a very beautiful city. I hope you guys, especially the international colleagues, will have chance this time to visit Beijing. And about our department, we have 276 beds and about 85 surgeons. Every year, we will perform more than 16,000 cases. Among them is more than 10,000 cases of spine surgery. So it's a big number. And as to our department is the first spine training center in China. It's almost 22 years ago. We established the spine training center in our department. And right now, I'm the president of spine. I'm the 7th chairperson. And among the pre-6 chairperson, there are another 3 chairperson come from our department, Dr. Dang, Dr. Chen, and Dr. Liu. So in our department, I am the 4th chairperson of spine. And every year we published many studies. During the past 5 years, we published more than 800 papers. And as to our spine technique, we are the largest spine center of upper cervical spine, right? We call C1, C2. Right now, it's more than 4,500 cases. And also, we are the largest center of thoracic spine stenosis. As to the spine tumor, we have performed the first 3D print vertebral into upper cervical patients in the world. And also, as to the spine deformity, we did a lot of very severe deformity, especially thoracic kyphosis, and also the severe spondylolisthesis of lumbar spine. And right now, we received many very complicated revision patients, and they need to receive revision surgery. It's also a new challenge for us. And as to the minimal invasive surgery, last year we performed 1,100 cases, and they're all the endoscopic surgery. So in our department, more than 10 spine surgeons can use this technique to treat their patients. So we talk about the minimal invasive surgery. Obviously, is minimize the tissue damage and shorten operative time and reduce the blood loss. And also, it just a very small incision. And also, the will let patients go back to their walk position very fast. And as to the evolution of spine endoscopic technique, the history is not too long. It's just half century. And the most important thing that in 1972, the name cabin triangle let all the surgeons to know this name. And through this triangle, we did a lot of work during the past several years. And as to the 1991, the cabin, they report arthroscopic lumbar discectomy. It's a new technique. It's open a new era of endoscopic surgery. As to our department, it's about 32 years ago, the Professor Chen, he was also the pre-AO chairperson of China. And he performed the first percutaneous minimally invasive lumbar disc technique, use laser to treat the disc herniation. Is almost 32 years ago. So it means from that time, our department began to use this technique to treat our patients. However, during the past 20 years, we all focus on very complicated cases. As just now I mentioned, the upper cervical spine and the thoracic stenosis and severe kyphosis and tumor. So no patient, no surgeons like to do this very small surgery. They all like to do the open surgery and the very complicated big surgery. So they will feel that is a big doctor. And so we can do the big surgery. But right now, because the technique developed very fast, the endoscopic technique is widely used in many hospitals. So we realize that all the spine surgeons need to learn this technique, need to use this technique to treat their own patients. So it's very, very important. So began 5 years ago, I tell all my colleagues in our department, let them to learn this endoscopic technique. As to the history of spinal endoscopic discectomy, just now Dr. Ma has mentioned, and there's a Young's technique and thesis technique from Hochland and Rutten, Dr. Rutten from German. They have he has his own technique, and it called a keyhole, and they also use the technique to do the cervical spine decompression. So it's developed very fast. And from the 2010, the teeth technique is used. And go to the 5 years ago, the endoscopic fusion technique is used in clinic. So it's during the past 10 years, the technique developed very, very fast and is widely used in many hospitals. And also, during the past 5 years, not only the endoscopic disc the discectomy, but also the endoscopic fusion, and is also developed very fast and used in many hospital. And some spine surgeon, they can use this technique very well. They treat the very complicated cases, especially for the lumbar spine stenosis patients, and also the cervical spine the patients, even the thoracic spine patients. And with the development of this technique, at the early time, the surgeon used this technique just to do the disc herniation. They remove the herniated disc. The surgery is over, but it cannot meet the clinical the clinical demand. So many surgeons, they can use the larger size of the tube to treat the patients with lumbar stenosis. So there's IC equipment. However, it's not very suitable for the patients. They have already used to use the open technique. They mind that like open surgery, we need to explode the lamina. We can see the bone. Then we remove part of the bone, and the next step is for the surgeon. We do the open surgery. Is very important that we must see the nerve root or the dura. Then we protect them. After that, we remove the herniated disc. This is a very common steps for the open surgery. So just now, I mentioned the TEAS technique and the Young's technique. Even the IC technique cannot meet our demand, especially the surgeon who do the open surgery a lot. If they want to learn, it's very difficult for them to change their mind. So how to treat this problem? I think the endosurgery technique is very important because it can use the open surgical mind and use the open surgical steps to do the surgery by the surgeons. And no matter you from the posterior approach or from the transforaminal approach, this technique will help us to see all the area we want to treat and to find the best point. And then we treat that point and remove the disc and remove the bone tissue to achieve the decompression. Let us say the literatures shows, and there's many RCT studies compare the endoscopic technique and open discectomy technique. We can say the 1 year's follow-up, these two groups, there's no difference in the clinical outcomes. And also, it's very important because many surgeons, they focus on the repeated surgery. Some surgeons who do a lot of open surgery can say that this endoscopic technique will let to increase the rate of repeated surgery. But from this study, we can say that 5% versus 6% is almost the same. So there's no difference. And also, for the endoscopic, it will have less blood loss and shortened length of hospital admission and earlier post-operative mobilization. And this is another meta-analysis. It's about 500 cases were included in this study. And from this study, we can say that we can find that there's no difference also not only in the clinical outcome, but also in the recurrence rate and also reoperation rate. There's no difference. And the only difference is also that the less length of hospital stay and the less time to return to work. But there's one thing we need to know, that there's inadequate decompression more in endoscopic surgery. This is another meta-analysis, and we can say as to the complications, almost the same compared with endoscopic and the open surgery. And also there are some different as to the bed rest time and hospital stay and low back pain. And the endoscopic group show a good, better outcomes. But as to the recurrence rate, the endoscopic group a little higher than the open group. And this is my my patients. As to me, because I do a lot of open surgery, just now I mentioned I do a lot of big surgery. I began to learn this endoscopic surgery is about 5 years ago, I think. But at that time, actually, I'm not very sure that this technique, whether or not can treat all the disc herniation patients. But for this patient, very big herniation in spinal canal, and I use this technique and remove the disc, and the patients got a very good MRI image and also a good clinical outcome. Here is another very big disc herniation patients, and the disc herniated to the L5 in the back part of the L5 vertebra. So it's sometimes it's difficult to remove it, but from the posterior approach, I use endoscopic technique and remove it successfully. This is another patient after the first fusion surgery, and it got stenosis of L5-S1 foraminal stenosis. So I use the endoscopic technique, remove the upper part of S1 facet joint, and then we achieve a good decompression. So all of these patients, we can use this endoscopic technique to treat. And you know, for the spine surgeon who learn and use this technique for a long time, and we can say they are very, very good endoscopic spine surgeon. They all in the meeting room, I think. The Dr. Ma, Dr. Sun, and the Dr. Chen, they all were the famous experts of endoscopic surgery in China. They can teach you a lot about this technique. And I want to say that we can use this technique not only to remove the disc, but also can do a lot of decompression of lumbar spine spinal stenosis. For example, the unilateral recession decompression, and the unilateral laminectomy, bilateral decompression, and even the unilateral laminectomy and bilateral decompression and the discectomy. With all of this, we can use endoscopic technique to finish. So let us see the papers, some papers results. This is a RCT study, and from this study, there's no difference between the endo ULRD is the recess decompression and the micro endoscopic recession. So there's no difference as to the clinical results and the revision rate. But the endoscopic the group has a little higher complications, but it's less operative time and fast time to go back to work. And this is another RCT study. We can say there's also there's no difference in clinical results. But in this study, the complications rate is higher than MIS group instead of in the endoscopic group. And also right now, there's a new technique. It's not only a unipulsional scale, it's UVE. It means the two pulsional technique. And as to the UVE, it can shorten the learning curve, and it can do a lot of decompression, especially the central canal stenosis of lumbar spine, and it will give us a wider fields of view, but it will more blood loss, and it's more damage of the muscles. And here is the typical case is central stenosis of lumbar spine, and we can use this technique to do the whole canal decompression, laminar decompression. And here is the thoracic stenosis, and this is the Dr. Sun's patients. He used this technique can do the decompression of thoracic stenosis. So right now there's many endo leads, and from anterior, from lateral, from posterior. And among those techniques, I believe the endo leaf should be is very promising. And in the future, more and more surgeons will use this technique to treat our patients. And so right now, the new development of the endoscopic surgery is we not only can use the endoscopic equipment, but also we can use the navigation, which will help us to do the surgery, especially do the pedicle screw incision and to do the to do the lumbar fusion surgery. It will shorten the operative time and let us put the pedicle screw very fast. And there's advantage. It's obviously I want to read so many words, but there's also some disadvantages because it has a longer learning curve, and it needs the surgeon have a very good endoscopic technique. And then they can, based on the technique of their endoscopic skill, and then to learn this complicated skill. But I believe everyone, if we realize this technique is very promising, it will widely used in the future. I think right now, everyone, we need to learn, we need to use this technique. And we also can see the results from the literature. We can say that the endo T-leaf versus MIS T-leaf and open T-leaf, there's no difference in operative time and complication rate, fusion rate, and even the clinical outcome. But there are some difference in the blood loss and the length of stay in hospital and reduce time to ambulation and lower pain of low back. And this is a good thing for the patients. So if we use the endoscopic T-leaf, the patients will got a better clinical outcome. However, we need to avoid the complications, especially the very severe nerve damage complications. Here, another meta-analysis, and there's no difference in clinical outcome and fusion rate and incidence of complications. So the endoscopic fusion rate is from 72% to 100%. So it's similar to that of misleaf. So we don't need worry about the fusion rate. And as to the UBE and the misleaf, there's also no difference in post-operative midterm low back pain and lap pain, and also no difference in fusion rate. It means the UBE is also a good technique. We need to pay attention to. We need to learn. And this is some patients, we use this technique to do the endo-TLIF. So take-home message, endoscopic decompression surgery is ideal procedure for lumbar disc herniation and also suitable for short segmental stenosis, especially for the fusion. And endoscopic fusion is just now, as I mentioned, is promising methods. However, it still have a lot of challenge. We need to learn. We need to pay attention to this tactic. And right now, I think the better way is for all the spine surgeons is to, we need to master both open technique and endoscopic technique. Thank you. Thank you so much.
Thank you. Thank you, Professor Lee. Thank you for your presentation. Any questions for Dr. Lee? Okay. Okay. We change a little of our plan of this morning. The next, we will begin to prepare for the next operation. And first of all, we let Dr. Xu Derong introduce the case. Yeah. Oh, sorry. The next presenter is Dr. Chen Bolai. I make the wrong. His presentation is about the keyhole technique for the treatment of cervical radiculopathy. Welcome, Dr. Chen.
I'm sorry. Below, spine endoscopy is widely used in lumbar diseases, and more doctors are paying attention to the this technology application in the cervical diseases. So today I want to introduce this technique in the cervical diseases. My picture is about the experience in the clinical application of pancreas endoscopy cervical disease, include discectomy and cervical diseases, stenosis. Maybe I like use Chinese 所以因为颈椎病其实现在在我们临床也是非常多见的。那么在颈椎外科里面已经发展到从上个世纪50年代到现在已经非常成熟了。但是如何把这个颈椎病我们常见的神经根性颈椎病还有脊髓性颈椎病，我们平常要用外科手术来解决的这些颈椎病，如何用微创内镜的办法来应用到颈椎？那么 cervical surgery are more and more accurate and minimal invasive and intelligent is my group arm. 这个I think the endoscopy have many advantages. The first, less tooth injury below 非常少的创伤，很小的创伤。那么而且出血非常少 ，little bleeding. And my patient is happy. Is the fast with happy 这个 patient with habitation is the left my patient is very happy. And 他有非常这个保留椎节的 automotion is a lot fusion surgery and reduce health cost. 那么它有非常少的费用，这个是我们微创内镜 endoscopy in cervical surgery is the advantage, many advantages, I think. 那么其实在颈椎的微创内镜手术，那么它主要是有2种手术用路，那么当然有 anterior and posterior。在临床上用的更多的is the posterior percutaneous endoscopy surgery. The have two 常用的有2个常用的技术，第一个就是椎间盘discectomy, and another the surgery is the laminodectomy for the stenosis. 所以目前有2个技术。那么我们说的这个技术come from the keyhole cervical keyhole surgery. 所以首先我们要这个 clean the softness on the laminal surface. It's cervical fossette and up and lower. Step 2 is close V-point. It's the laminal V-point.首先我们要找到上下关节突的交汇处。It's easy the process. and free phenomenal lobotomy。首先，我们就是要用这个Germany 冰的 lamina。I will review the starting point of the yellow ligament. This is the already been the lamina and use the condition and quickly and quickly and easy the condition use the condition pull the yellow ligament and will remove the yellow ligament. And see the reticule and sit can explore the nucleus properly. Purposes. And see the nerve root, can leave nerve root and will remove the predominant nucleus. Will maybe the nucleus will be in the vacuole root. 它有时候会这个游离的水核，它会藏在神经根的腹侧，还有这个脊髓的这个腹侧，所以有时候我们要仔细的去寻找，最后要确认confirm the reticular release 这个神经根是否已经松了松了以后，那我们这个手术就可以结束。上面看了一些这个 case， we beginning the in our team begin the keyhole endoscope from 2014. Now about 10 years. Auto 400 cases use the endoscope in cervical disease, include vertical and the cases. This is the discoloration 就是单纯的椎间盘突出的病人。Is can see the cervical 6 level 6 and 7 herniation， 所以我们就用微创内镜的办法，这个能很快速的能把这个椎间盘突出的水核use the keyhole surgery 完成这个椎板刚才的这个手术的这个 step and step 的这个步骤来完成这些手术的操作，那么非常容易的这个可以看到我们的神经根还有水核的摘除，而且它是保留这个颈椎的运动功能not fusion surgery only the disc istomy so can protect the cervical automotion. The second case is the with Wilson surgery following ACDF 的 cases， 这个病人曾经做过这个 ACDF 的 surgery，but 但是他这个出现的这个神经根的症状，后来我们发现 this cases stenosis 的 group。 So we use the endoscope, solve the nerve full level. The first level is the HDF level, and another is herniation. The after surgery MRI can see and CT can see the surgery process. The first case, this is ossification of the ligament flavin. This is the highest weakness of the limbs and more than 1 year. COA is 12. This MRI can see the compressed use the endoscope surgery. The upper cervical disease is the cervical tool, and use the endoscope. It's okay. Our team use the scope, use this case， 用的这个第二节的这个颈椎的椎管的狭窄，又是环韧带骨化，那么这样的一个脊髓型颈椎病压迫脊髓的一个病例那么其实这种病例我们也团队里面这么多年4年来也处理了好几个，这是一个比较典型的病例。我们也是通过这样的一个技术来处理这个颈椎管狭窄伴有环韧带骨化的病人。那么这个单轴内镜它是完全可以做得到它一个和我们开放手术一样的一个结果。那么首先这个use the tumor the finger the lamina and use the collision and piece and piece collision 的剩下的这种ligament and 环韧带。The last you can see the 这个 dulum very and post surgery can see the CT MRI is very good the compress, but and not fusion only compress, and can see the after. Another the cases is for the 颈椎环椎缔结 the first level is stenosis. We can sometimes will 遇到这样的一个病人，他没有明显的脱位和不稳 ，only stenosis. We can do the 我们要做的工作就是要把它进行一个部分的切除和减压，所以怎么去完成它？那么也可以通过这个微创内镜的技术来进行这个环椎的一个切除。那么这个就是我们在掌握的内镜的技术非常熟练的情况下，那么可以不断的拓展它手术的适应症。这个时候其实我们也看到它一个脊柱微创内镜的魅力它的一个魅力所在。那么这个病人他一样的看到他是一个狭窄。 那么当然，我们对于这些疑难的、困难的病人，可能会用到我们的 robot，会 use the robot， maybe the navigation help we 的确定的这个位置这个位置以后，那么才能工作通道再放进去进行下一步的一个操作。This is a Chinese robot。就这个精准的定位后，再进行这个椎板的环椎的一个磨薄 ，think the first the lamina and use the collision piece and piece 去除这个剩余的一个韧带以及骨质。This after poster the MRI and CT。The arrow indicated the spinal cord complex would be especially at the level of the atlas. So I think the large endoscope system is effective for cervical disc herniation and stenosis. 这个 application and the DSM. Two, postally percutaneous endoscope cervical surgery can be test field into PCD only herniation and stenosis from the keyhole 的 keyhole 技术的一个扩大。The large endoscope system work more efficient with a shorter operation time. Three, the combination of percutaneous endoscope, cervical surgery, and lobe maybe and navigation technique. The safety of surgical human has been future enhanced. Thank you. Thank you.
Okay, thank you, Professor Chen. The next, let's have a short coffee break. We can have a five minutes break and come back here to go on the next presentations and the live surgeries. Okay.
Introduce my team in Guangdong Province Hospital. This is the biggest hospital in Chinese medicine. Maybe in our team every year about 6,000 spine surgery every year, including 1,300 endoscope surgery. Welcome you next time. When to go to my hospital, go to Guangzhou City. Thank you.
Okay, have a break.
它这个视频，好过去，好的吗？两个是一样的。这是不是要重新进入一下那个讲出来了？啊，先看。一会儿就研究的模式对，这个是电脑这个热性。但是我接着看看，但是啊，是。啊，这个还有一个文件，就分组的。接触史，对，观摩的水平。然后这次西班牙52个，西班牙现在是哪个？西班牙的上是化验这个东西。换啊，因为你要换图去回顾嘛。好，那就直接开始。这边不用镜头会了是吧？不用哈 ，OK。哦。是的，是。哎，看不见了，在桌面。啊，但是你刚刚考虑情况呗。打开了，是的，打开了，在任务栏可以找。打任务栏。后面应该没有那个。 这么多病，这个是你都是还有是眼睛主要是的眼睛啊，你看了眼睛那儿是，就试一下，试一下，我放一下，这大电话了，这个就上吗？对，我来，都去，先把这个先关了，先关掉。是这个吗？对，是这个。哦，那我这会儿怎么先最小化吗？就放在最前页就这一页就这样。待会儿除了说会先就是邀请上来直接对，老师刘老师就要做模型了，我先听下一个老师讲解一下这个步骤，我都是在翻着跟他们讲。然后那个后来，王老师待会儿讲完以后应该是水果老师会邀请，比如说这个 case report， 然后您再上，然后您的片子待会儿我先帮你准备好，那个分组是吧？对，打出来，对，最小，对，打开了，也打开了，对，也一点上了，这是分组是吧？不用，它有个病例。哦，病例，那我把病例塞在里面，塞在里面。稍等啊，是这个，是吧？就放在这儿，很多我看乱，把那个夹在这儿。好吧。然后后来到时候是这样，可能王老师讲完以后，你上啊，然后你讲 case report 之前，你跟大家提一嘴，就说我们 case one 是这些老师可以go to the person room 去看这个。哦，那个时候他们还没去，是不成长，对的，基本讲完来后再去，一般是讲完分组。对，然后你打给我怎么就是说 this is our group list and each lab case we will invite one group to show the list. So next day one person will not have step 就是我们在那等着他们嘛，我们带着这个就给他们实录一下。你大概理解了吗？我刚讲的，对，就是有的放这个的时候，我说就是他们一会儿，对，就是说一个人每一组看一台手术，就是那个整个组的流程。我待会儿一台手术这一视频一版是这一组的老师，就是说我们没有，然后接下去就跟你的，好的，把你这个。俄罗斯前一天。
发现虽然
还有没回来的啊？Okay, the next, let's welcome Dr. Wang Xin to give us a presentation about the spine endoscopy surgery in transforaminal approach. And after this presentation, we will see the live surgery of transforaminal approach, the discectomy. Okay, welcome.
Okay. So today I would like to give everyone a brief introduction into endoscopy for spinal. Okay. So hello everyone, good morning. I'm Dr. Wang Xin. I would like to give you a brief introduction into EndoSurg for spinal endoscopy in transforaminal approach. I'm specializing in spine endoscopy for many years. I come from the first hospital of Lanzhou University. So this is my fifth time at EndoSurg International Training Week. Okay. So my hospital located in Lanzhou, which is 1,800 kilometers away from Qingdao, where we are now. So I always come to Qingdao. So actually, this is my second hometown. And Dr. Ma is also my best friend. So today, the context will be divided into 4 parts. First is transforaminal approach related anatomy of the local anesthesia. So have any of us ever done a transforaminal approach? Who have done this surgery laterally? No, no one? Okay, so do you use general anesthesia or local anesthesia? Actually, local anesthesia is a relative safe way for the beginner, but you must meet this kind of a situation. The patient is still complaining of pain during surgery. When I doing the surgery at my first several case, when I using local anesthesia, my patients will complain, "Doctor, I still feel pain. Do you use real medicine?" I told him, I use the right medicine. So I think it must be my problem. So the following are the main points we should pay attention to when we giving local anesthesia. So there should be 3 pauses. during the local anesthesia injection process. The anesthesia is injected at each pulse. First one is skin. Yeah. The next is deep fissure, then artificial process. So we should look at the distribution of the nerve in the capsule joint. The posterior branches of the spinal nerve are divided into medial and lateral branches. So branches of the lumbar dorsal at the level, for example, L4, L5, MB means medial branch, LB means lateral branch. So that means one facet joint is controlled by two segments of the dorsal branch of the spinal nerve. So this picture looks more clearly. So the medial and the lateral branch of the dorsal branch of the spinal nerve are separated here. Yeah, much better. Are separated at a distance of 1.5 to 3.5 millimeters above the transverse process. Both of them needed to be blocked here, here, here. So one injection local anesthesia try to penetrate into the joint capsule, and the feeling under your hand is to have a little resistance. If you feel loose, it's not the right way. Okay, next part is related anatomy of the transforaminal approach. We all know the foraminal size is different at the different lumbar. We should be familiar with the structure of the foramen. So everyone, I think if you're doing this kind of surgery, even open surgery, we familiar with the structure. So I will not go into details. But look at this clip. What we can see. So we can observe how the foramen change, larger or smaller. So one flexation, the foramen, the size will small, is big, but one extension, the foramen size is bigger. So another question is here. Whoops. So if doing this kind of surgery, do you always bending the table? For me, at my first several cases, I will use bending table. It can stretch the fat joint, expand the foramen, eliminate the lumbar lordosis, and increase the posterior edge distance of the intervertebral space from the X-ray, because this is standard lateral view, is extension, flexation. From the picture, we can see the foramen size is bigger than extension position. Okay, next part is also important about foramen related structures. We have nerve root, dorsal root ganglion, and the artery and the vein. So a reticular vein is on the dorsal side of the dorsal root ganglion, and artery is on the ventral side of the ganglion. We still have intravenous veins at here. Look at that picture. When we put the tube at here, it's obviously much higher, so it will sometimes damage the nerve root, like this video. Here, you can see its axial nerve is destroyed, so it's very bad. We should avoid this kind of a situation. For this, reticular arteries We can see here much bleeding. Here. So we should avoid this categorization. We can pre-bleeding. Why? Okay. So for intravenous veins, I marked the rotates at here. It's on the junction between the SAP, the root of SAP, and the transverse process. We can see the intravenous. For external foramen structures, we should pay attention to the anterior transverse ramus and the dorsal ramus at here. I use green and blue to show the vessels. So for Rabin triangle, Cabin triangle, we should familiar with the structure. But some scholars have proposed that the Cabin triangle should be the three-dimensional and should not be simple considered two-dimension. From a three-dimension perspectively, the Cabin triangle should be composed of 4 parts. And the upper article process of the lower vertebra should be the 4th part of the Cabin triangle, which is often removed by TLIF to expand the working area. This picture from Dr. Ma's cadaver course is a very precious picture. Everyone thinks the Cabin triangle is the safe zone, but even chemists, the Mr. Chemist, they do not say, the Cabin triangle is safe. What is safe? What is safe zone? Actually, we should cut some bones. Later, I will illustrate how to cut the bones. Even you cut bones, you will show the real Cabin triangle. That is safe. So when you do cadaver in the next few days and observe the surgery, we can have candle failing. So next part is how to recognize anatomy structure. Here is the tip. First is the tip of SAP, and here and expansion of the SAP. And from the corner means L-shaped junction of the SAP and the pedicle. Because we can say it again. Tip, expansion, here is corner. Then we can stripping the soft tissue. Cranial, we should avoid bleeding. Here is an important structure, external nerve root. Caudal is intervertebral venous and anterior transverse ramus. Here. Corner, you can see the artery here, intervertebral venous here. So for foramen anatomy, there are scales here in the inner surface of the femur. We also call the trifan here. 7, 9, 11 millimeters. So below of the sliding of the femur, so anti-clockwise is recommended. First is anti-clockwise, then clockwise. You can cut the bone easily. So next we can review the basic steps of surgical operation. Well-known spinal endoscopy has gone through different stages: Young's, Chase, IC, and EndoSurg. And they have the very good instrument. The diameter of shaft from 6.5 to 9 millimeters. This picture, Dr. Mars provided me. I think it's directly show how the vision size, we call the visualization. So what is EndoSurg? Actually visualization. So compared with traditional endoscope, application of EndoSurg Plus will increase the infield of view by 50% and efficiently during the superior by 30%. So through the evolution of the instrument, we can get unbelievable broad view sight. Here's also some instrument. Their diameters is bigger. We can also compare the EndoSurg and open surgery. We can got more small incision, faster recovery, and patient references. How to do the surgery? First, we can mark some lines. This line from here. That means the distance between the two pedicle centers in the same vertebral body is 1L. So this line here, this line is connection of the center of the pedicle of the two adjacent vertebrae. So make a vertical line here, like this line. Make a vertical line with this line. The distance with the middle line range from 1.5 times L to 2.5 times L. So it depends how fat the patient is. If the big heavy weight, maybe 2.5 L. But if thinner, for thinner person, maybe 1.5 L is okay. But for most cases, 2L is enough. Here is the video from the UNTech. We can put the Bible, hold the SAP, the ventral side of the SAP. First, we should make a skin decision, then put serial dilator, then take X-ray to observe if you are the right segment and the location is good or not good. And in last step is inserting working tube here, called U tube at here. Checked by X-ray. So the position is satisfactory. Let's see the two optical typical cases. So the first one is 22 years old male non-nasal patient, mainly felt in the left buttock and the back of the calf, the SLR 40-degree positive. From the CT, you can see the herniated protrusion at here. At first, expose the SAP. Recognize the anatomy structures, just like previous slide I show everyone. Just for LTH, so we needn't do much resection of the bone. You can see here is a disc. On the 12 o'clock, actually is the dural psych and the nerve root. After surgery, the disc herniation is removed. The second case is LLS plus disc herniation, 65 female years old, numbness and pain and mainly felt on the back of the right thigh and the post-lateral leg, right SLR 40-degree. From the CT, you can see the central canal stenosis and the disc herniation at here, protrusion. We have 4 diagnoses, and we put U-tube at here and see if the location is good. So still we should expose the structure of the anatomy structure I showed you in previous slide, the tip SAP and the expansion and the corner. So generally speaking, we have three reamings. First, we ream the tip of the SAP here and proxy ending point of the ligament flavor. The second reaming, we can move to the ventral side of the middle facet of the joint. The third reaming, we can expose the base of the articular process, distal ending point of the ligament flavor. And then we can give a very good dorsal decompression from dorsal side, use forceps to cut the yellow ligament. Then we remove the herniated disc from the ventral side. We call it ventral decompression. This pre-operation and post-operation. Here's also the pre-operation and post-operation MRI. So the spinal stenosis were relieved and the herniated disc removed. So all of this just a brief introduction of the EndoSurg from lateral side. And I hope this will be helpful to you in your coming days as you observe the surgery and perform in the cadaver lab. So this is my city. A city through the Yellow River, a bowl of delicious beef noodles, a statue of the mother of the Yellow River. So very good climate, beautiful scenery. You're welcome to Lanzhou. Thank you.
Thank you. Thank you, Dr. Ma. Thank you, Dr. Wang Xin, for your presentation. Okay, and next, all of these presentations are usually hypnotic, but the live surgery should be exciting. Okay, so let's the next we'll see the live surgery, and first of all, let Dr. 谁来介绍?
Okay, hi everyone. Before the case report, please check out this group list. And each group can observe one operation. And after the case report, we will there are staff outside. They will take you to the operating room.
Okay, group one composed one count of CMN. After the case report, CMN and after this introduction.
Okay, today I'll present the case of a 24-year-old male patient. The patient's primary complaint include low back pain and right leg pain, which have persisted for 15 days. The pain radiates along the posterolateral aspect of the right thigh and worsens with standing and walking, but is revealed by rest. The pain pattern suggests nerve involvement, especially affecting the L4-5 regions, and the straight leg raising test was positive on the right side at 50 degrees, while the left side was negative at 70 degrees. And from the X-ray, we can see there's no spondylolisthesis at the L4-5 levels. And from the MR image and the transversive section of the CT scan, and we can see the spinal stenosis.
And
the patient was diagnosed with lumbar disc herniation, L4-5, and surgical intervention was deemed necessary, and the proposed procedure is PETD using the EndoSurg Plus system. In summary, this is a case of a 24-year-old male presenting with lumbar disc herniation at L4-5, causing low back pain and right leg pain. Surgical intervention using PETD is planned to address the nerve impingement and improve the patient's quality of life. Thank you.
OK，Thank you。回到刚才那个最后的那一张啊。OK， 好 ，Group One，Go to the OR now
申老师，
Yeah.
好。
And Group 2 and 3, we can have a short discussion about this case. This is a very common case, right? With degenerative spondy lumbar disc herniation and lumbar spinal stenosis without spondylolisthesis or any other deformities. And any question about this case, about the diagnosis and the treatment plan? How would you treat this case by now in your clinical practice?
I think it should be like microdiscectomy. Yes. Microsurgery.
It's a good choice, I think. Yeah. Only 2 weeks. Or 2 shots. A conservative treatment. Yeah. Yes. I agree with you. Physical injection, nerve block. Yeah. Sure. Yeah. Okay. A good advice. But today we focus on the operative techniques. I think maybe the history of this case, maybe there is, I'm not sure. Is this really only 2 weeks of pain? I'm really confused about. Oh yeah, 15 days. Yes, it's really short. Thank you. Yeah. 24 years old.那手指到什么程度了？哦，已经转过去。Okay. Oh, the surgery has begun now.
可以了吗？转播过来了，之前的。转播过来吗？王飞。接受完了，应该是已经。对，现在到是不是图像要转播过来了，或者什么的？问清楚。
啊，
转播过来吗？
传力在做是吧？
之前的，小之前。
传力，
孙主任。
能听见我们会场的声音吗？
能听见。
啊，好嘞。那个你就专心做手术哈。我们这边我和马主任我们来介绍一下你的步骤。然后到了关键的地方，特别需要大家关注的时候，你可以来说一下，就是你的主要的精力放在手术上哈。
OK， 我要不要介绍？Should I introduce the X-ray, AP film, and the lateral film? The position of the tube.
啊，可以。
OK. The tube we can see from the X-ray, AP film, and the lateral film. On the AP film, it was on the lateral side of XAP, and In the lateral film, you can see it's just on the ventral side of SAP. And I also have exposed the basic anatomy. You can see from the this is the SAP. This is the tip of SAP. A little bleeding. I will stop it. And 12 o'clock is the IAP. And in the center of the film, in the view, in the center of the view is the tip of SAP. And here we can see is the ventral side of SAP. And below it, 6 o'clock is the brain. Okay, now I will begin the operation. I will perform the first reading on the table of SAP. Okay. 不是换句。或者啊，说这个。之前，
9点是头端吧？这是右侧。
The 3 o'clock, 3 o'clock is the cranial, and the 9 o'clock is caudal.
差不多。对对。Now we can see the foraminoplasty performed with the reamer, yeah, to part of the SAP. And now we can see the yellow ligament and the epidural fat. And now it is very near, very close to the transverse nerve, L5 nerve.
帮我们显示一下椎弓根的上壁表面。
Okay, it's
at the 9 o'clock, this way at the 9 o'clock is the cranial part of L5 pedicle.
In fact, I can touch it, but because there is lots of soft tissue and blood vessels here, so I don't.
The L5 pedicle is a very important landmark. Landmark for us to decide where should we to cut the SAP. If we cut lower than the cranial part of the pedicle, it's too caudal. We may cut too much bone structures. It's not necessary. But if we cut more cranially far from the pedicle, it's dangerous for the exiting nerve.
It's here, and I can figure it.
Okay, you can go on. Below the epidural fat, we can see a white structure that should be the disc. And during all the surgery, we should keep on to practice to stop bleeding. Any bleeding should be stopped at any time to make sure we have a clear vision. This is very important for the safety of the nerve.
Here is the transverse process. Here. And the transverse here.弯前，小弯前。
During the surgery, we should always keep clear orientation in our mind. We should always know the 12 o'clock is the back, and the 3 o'clock is the head, and the 6 o'clock is the anterior, yeah, and the 9 o'clock is the caudal direction, yeah.
Professor, I have exposed.
So we can see in this region, the 12 o'clock is the SAP, and the 6 o'clock is the disc, and we cannot see the exiting nerve, but we know the nerve stay at the 3 o'clock and in that direction.
7点左右有一个出血点，你要找到它，把它止住，否则呢，我们在现场啊，一出血视野就看不见了。
OK， 好的，主任，我正在指示。
看吗？嗯。
Bleeding is a really difficulty for endoscopic surgeries. I remember at the beginning of my experience for performing endoscopic surgery, nearly about 50% of the whole surgery time has been used to stop bleeding. But this is really important. With more and more experience of this kind of surgery, we can stop bleeding more and more quickly, and the time expansion can be decreased. We can see Dr. Zhu use the reamer to cut more bone structure of the SAP to get more room to go into the foramen. This is a very key difference between the EndoSurg and the traditional teeth technique. We can perform the foraminoplasty many times, just as we to realize full enough room to perform the discectomy and to show the nerve structures clearly, and without the help of X-ray, we just to decide how much foraminoplasty should we to get by the anatomy landmarks. Okay, please. It depends. It depends. I think any kind of surgical tools can be used as you like. Yeah, and the reamer is, I think, is cheaper. And also is really efficient. Yeah.
Here you are looking at you never and it will feel because you go
Yes, the possibility of use at this kind of condition may be happy. Yes, so we need to keep the vision clear enough, and we can see where we are cutting, and also we can see the depth from the inner wall of the reamer. There is the three lines, 5, 7, 9 millimeters. So we can know how deep we go in. Mm-hmm.
And then you know where you are, and then you want to put the rules of but if you unroll and then you can see the 3 lines, and then you will also It's 579. Yeah. Millimeters.
And we don't go through all the way down to cut the bone structures. If we can to how to put it, we'll think you have nearly almost to cut the bone. You can bend the reamer slightly, just like we perform the open surgeries, use the osteotome and hammer. We don't cut all the way down. We cut deep enough. We bend it.
Yes, and you can see it when the bolts, then it's rotating the paper, and then it's I mean, this case you don't move paper, and then you just like that's one side, and the bolt is and then you go.
But now we can see he's cutting the ligament flavor. If only we use the reamer to cut all the bones, the SAP all the way down, and the ligament flavor still remains between the reamer and the nerve structures. Now we can see the gap between the ligament flavum and the disc. This should be the bottom of the SAP. Use the reamer to cut. Okay.
I'm going back to Francis. See you.
See you. Thank you. Have a good trip. Now we can see the tip of the T-shaped tube. After we take out the reamer and put the T-tube into it, there are two tubes. The outer one is a U-shaped tube. The inner one is a T-shaped. We can see the tips. Okay, by now in the middle of this vision, we can see the herniated disc, just this part. And by now we cannot see the transverse nerve because the transverse nerve is pushed posteriorly by the herniated disc. After we remove the herniated disc, the transverse nerve will fall down to the normal position, a normal location.我觉得够了。This is the ligament flavum. After cutting the posterior ligament flavum, we can see the nerve root, a part of the nerve root, and some of the epidural fat. Oh, 小心哦。
南前。
This is a general anesthesia. I think all of your cases will choose general anesthesia, right?
全麻肌松是全麻的一部分。全麻肌松之后，然后就是弯掌规，不是常规。在欧美有要求。对，那个检测用的很频繁，包括这种常规的检测，可以说常规检测，咱们。
I prefer to. There is two choice now. The first is to remove much more SAP and IAP, and the other is just keep to pull out the disc herniation and waiting for the decrease of the nerve root. But for this patient, I think I should remove much more IAP to enlarge the space. 换句部分。
这个病人呢没有向上脱垂，所以呢你不需要去除过多的下关节突啊，因为向尾端偏移一下，向尾端走一走，可能会更容易显露椎间盘的背侧。这。
我刚才做的是要再往背侧长一点，这个判断是基于这个膀胱间隙的位置，因为这个我们可以看到这个是膀胱间隙的位置。目前的话，对于这个膀胱间隙的顶端的黄带来说，显露的还是有点少，所以我觉得背侧如果要因为这个肩胛是一个很向上顶得很厉害，往背侧顶得很厉害，所以我觉得如果要是空间不够的话，这么掏可能会有点费劲。这个。放调起来起来起是什么？之前先给我之前。
This step is a little dangerous for the transversing nerve. We need to make sure to recognize where is the nerve root, where is the disc, the fibrous and the posterior longitudinal ligament. You can see the border, the herniated disc compressed, compressing the nerve root.
This is the top of the disc. I have to find the top, then I can take it out.
You can see this is the disc, and this is epidural fat, and this part should be the posterior longitudinal ligament, and we need to remove all of this part and to protect this the nerve. This area below the posterior longitudinal ligament is relatively safe, but when we try to cut the ligament, we should be more careful.
I have put out some disc herniation, so we can find the nerve is more clear.
The nerve root and the posterior longitudinal ligament are both white color, but we can see the shape, and the shape is different, and also there are some vessels, small vessels outside of the nerve root. After the disc be removed more and more, we can see the nerve tend to be floating outside and outside, and more loose.
Okay, we have over the top.
Posterior longitudinal ligaments be cut.
After all the talk, the surgery will become easy.
For this kind of young cases, we distinguish the ligament flavor and no need to remove too much the flavor. But for those elderly cases, maybe the ligament flavor is one part of the spinal stenosis. You need to remove enough flavor is necessary.
小新，这套工具的直径是不是变了大小？
And now we can see clearly to produce the punch to cut more fibrous annulus. And you can see the teeth of the punch to push the nerve backward. This procedure is relatively safe. Only we can see very clearly.
收到了。
This is the L5 body, and this is the L5 nerve. And by now, I think he's trying to remove this part.
这边没过，我去了。转钱过来。
The conversion has been finished almost. You can see the nerve. After the deconversion is enough, you can see the nerves look really.
After we reach the ventral surface, now I can remove the central disc condition and perform the caudal and the parietal decompression. Okay, Professor Ma and Professor, do you have any other statement?
Yes, very clearly. Just stop all the bleeding and let me see the floating nerve. Yeah. Yes.
The right is the annular fibrosis and ligaments. And this is resins.
Yes, the decompression is really very, very enough. Okay. Can you stop the irrigation?
Okay.
Yeah. Let me see if there is still some bleeding.
Yes,
Yeah.
I
Yes.
should looking for it and stop it.
Yes. After we finish the decompression step, we can stop the irrigation to check if there is any bleeding. If we stop after we stop the irrigation after about 10 or 20 seconds, and the vision is still very clearly, it's good. We can very happy to stop the surgery.
So it's time to discussion. We have around 20 minutes. If you have any comments, any questions, would you please to put it up? I believe you must have some comments. All right. Yeah. Yes, let's back to the patient information. I introduced at the beginning of the surgery. Let's show the PPTs. 把这个病人的幻灯片子再打回去。我们要 review the surgery.
是这个吗？
Yeah.
是这个吧。
你播放状态下，然后找到这个病人的，这个其中有一个，来，我们再回过头来看看，对。不，他有那个，他有一个把那个幻灯片那个播放激光笔给我。 我再给我看看他的这个。So, any comments, questions? You? Yeah.
Two questions. Thank you so much. Well, the first question is if you have to search for the exiting route on the common basis when you perform the transforaminal approach. If you have to search for it or the exiting route, you have to search it or see it during the transforaminal approach, or you don't have to see it on a common basis. Yes.
Exiting the route?
Yeah.
You just mentioned exactly. Whether we should expose the exiting the route, it's needed. Okay. No need. Okay. We only expose try to find and expose the exiting the route only the stenosis of the foramen or the far lateral disc herniation. Yes, if this is a central lateral disc herniation, no need to expose the exiting the route.
Perfect.
Yeah.
I have a second question. I have a delayed instability in the spine in the case you remove too much of the articular process. If you have some cases of instability in the spine or delayed listhesis because of the removal of the articular process.
Yes, usually we try to keep the facet joint intact yeah, after the foraminoplasty, really, yeah. That's the should be one of our standard aims. But today, this case, I think the joint had been harmed. Yeah, it's not the routine technique.
Okay, perfect.
This is a young case. It's only 24 years old. We hope to try to protect the facet joint, try to remove the only part of SAP, not to injure the joint. But this is not an easy case. I checked the radiological data again and again, try to find why the surgery to remove so much facet joints, because the top of the herniated disc is around the central, and it's not easy to expose it. And at the beginning of the surgery, they try to remove only a small part of the bone structure, but it cannot to expose the construction tissues. So they have to use the reamer to take more the bone structure, the facet joints, and then look back to the X-ray. This is the lateral X-ray. The tip of SAP is very small. You take out only a small part, you can find the joint, the capsule. So during the operation, we are afraid of the injury of the facet joint. But it is not a big issue because we have done a large number of lateral approach endoscopy, but no instability problem, and no low back pain happens. So don't worry about it. This patient has another characteristics that is the annulus fibrosus is so thick, and itself is the compressive tissues. We have to remove it out and then release the transverse nerve. The transverse nerve was pinched by the bulged disc and the yellow ligament. So the surgeon tried to take out the yellow ligaments, the posterior of the nerve, and the ventral part and the tissues. I have to try to expose, try to make more room to let the instrument to take it out. They have to do like this to try to get a nice outcome. Yeah.
Your question is really a good question. I hope to share another. You can see the herniated disc is almost at the midline. So if we go from this angle, when we try to get this area, we need to take more bone structures. We cannot keep the facet joint intact. So one of the skills should be go far from the lateral and let the angle of the puncture is more horizontally. Is maybe can help us to avoid to harm the facet joint. Yeah, this is a small skills, yeah, for the transforaminal approach.
Professor, just a question. Like this case, actually, will that be because near to midline, will a lateral position better approach in this case compared to a supine prone position for transforaminal? You mean the approach, the position of the patient from the start, instead of the prone position, but to put the patient in a lateral position, we also go through transforaminal. Just a question, sir.
What do you prefer? You love the supine or a lateral?
I actually at the worst of beginnings, both actually I've been exposed to both, so I've yet to decide which one is better. But I think still case to case basis per se. That's why actually, if I'm thinking that this case that if let's say the lateral approach in this position, a prone position, that the angulation might be too much, that I might at risk of violating the facet joints, then perhaps lateral is that a better position? Or that's my question, sir. 我的意思是，如果比方说 patient 是在躺着、在趴着的情况之下，比方说我们要去到这个 cross midline， 你看到 contralateral， 它的另外一边也是有点 stenosis。如果我是单纯的是这种prone position， 我要从我的一个 transforaminal 将那个角度可能会比较困难。所以如果在这种情况之下，我们在病人在搬侧卧的时候，会不会较好一点？这只是一个参考，只是。因为我有看过有的手术医生是在侧躺的情况下做手术，所以他去的角度可能会相对比较容易如果他要去到对方的话，而且除此之外，那个棘突旁的是耶路里根本，他拿取的摘除的方法可能会相对的较简单。
Yes, both these two positions are being used by now in our clinical practice, but actually the prone position is the most surgeon's choice. I think maybe for us spine surgeons, both perform the open surgeries and the endoscopic surgeries, we are more familiar for the prone position. It's much easier for us to get a very clear orientation during the whole surgeries. Yeah. I never perform the endoscopic surgery with a lateral position. Yeah. It's maybe this is one of the causes.
Thanks, Professor. Thanks.
In the end of the surgery, do you put some corticoids in the root?
No need, because the nerve root has been released totally. You can see the whole, the segment of the nerve. There's no pinch, and you mean that's the injection? Yes, yes. Since we do the EndoSurg surgery, we no need to use the cortical, and because the decompression is the first the aim. If you can get the totally decompression, they do not need the injection. Thank you.
If no more questions, so we finished all of the issues of this morning, and the next should be the lunchtime. Enjoy. And we will begin our afternoon part at 1 o'clock.
We have lunch here. Here you can take care.有这个是吗？有的是了。不然是那边哈，我给你放那边啊。
好嘞，好嘞，好嘞。
熬了时间。
这边。帮我插一下，我提前把我的电脑充着电。那我就先不在这充，就不然可以充也行。我就充点电，一会儿我怕我讲课的中间没电。
哦，好的。是不是用不了？
它简单啊，它的电脑它没有。
Good afternoon, everybody. Let's go on with the course. The topic of the next section is posterior approach of endoscopy. To start with a lecture of Professor Sun Chuiguo. Sun Chuiguo is a professor of Beijing University. Beijing University is the top one that university in China. And the orthopedic of the third hospital of Beijing University is the top one in the orthopedic field. And Dr. Sun is good at the endoscopic surgery and good at speaking. He's a professional instructor, and the topic of his lecture is the application of EndoSurg concept to posterior lumbar spine surgery. Let's welcome. Okay.
Yeah, hello everyone. I'm really very happy to share my experience with all of you. And today my topic is about the interlaminar approach. First of all, I'd like to share my understanding of EndoSurg. This is Chinglish. This concept came from China, and the maybe a group of Chinese spine surgeons introduce this concept. We can understand EndoSurg as a new endoscopic surgical instruments, just like in the room of this in the next the room. We can see so many new instruments, new surgical sets, surgical tools, and also we can understand EndoSurg as a new endoscopic surgical techniques, just like we see in this morning. We perform the transforaminal procedure. Use the EndoSurg concept. We can perform the foraminoplasty once and once again. Totally different from the traditional teeth technique to perform the transforaminal with the help of the X-rays again and again. And no X-rays needed during this process. And the X-ray, we use the X-ray only to confirm the correct level of the surgery. And after that, we go on the surgery with the open surgical mind. That's my point. I think EndoSurg, the key understanding of EndoSurg should be a new endoscopic surgical mind, not only a new techniques. The difference between the EndoSurg surgical instruments with the traditional teeth technique includes these two key instruments. The first one is the U and T-shaped tubes. The second is the external reamer. This U and T, this is U and this is T. U is the outer, is the bigger one. The U tube works as a soft tissue retractor in our open surgeries. During our open surgery, we use the soft tissue retractor to keep the wound, keep the incision open. And the other instruments can go in and out again and again. And the T-shaped tube, just like this, these two tubes can be combined together. And the T tube is a little longer than the U tube. The T tube works as a nerve root retractor in our open surgeries. The T tube can go into the spinal canal to push the dural sac, the neural nerves, to protect the neural nerves from the injuries. This is a very small change, but it changed our surgical mind. We don't need to depend on the X-rays during all the surgeries. We can during the surgery, we can confirm the anatomical marks. We know where we are and where we are going to. And just like the open surgeries, we use our knowledges about the anatomy to decide where to go, how much we need to cut, how much we need to go far away. And just like to perform open surgery with endoscopy. And the reamer is really powerful tools. It can work as the osteotome in our open surgeries, use it to cut the bone structures, not only the lamina, but also the SAP and sometimes the OPLL, such as the hard tissues. And also it can be used to cut the soft tissues, such as the yellow ligament. I will show you next. So with these very simple tools, we changed our surgical mind to or in another word, change back to the open surgical mind. Okay, this is should be more familiar for all of us. This is a very good, very important upgrade of mind. Oh, let's come back to the approach selection principles. We all know, we should all know this picture. We divided all of these areas into 4 zones. We named it 1, 2, 3, 4. The number 1 should be the half of the dura sac, and the number 2 should be the lateral recess, and the number 3 and the number 4 zones is separated half and half of the foramen. So for interlaminar approach, we can use this approach to treat for the disc hernia at zone 1, zone 2, and sometimes zone 3. But for zone 4, for this far lateral disc herniation or extra foraminal disc herniation is not suitable for interlaminar approach. We should choose the transforaminal approach for this kind of cases. And in the sagittal plane, we can see sometimes we can see the nucleus removes to cranial or caudally, and all of these kind of conditions can be treated with the interlaminar approach. And the transforaminal approach may be not able to make sure to remove all the nucleus. Let's go on to the surgical details. The first question is also the position. The prone position is my choice, especially for interlaminar approach. This one should be better. Let's see a typical case. This is also a 40-year-old female, 24 years old, right leg radiculopathy for 3 months, and failed from the conservative treatment, and the pain is really severe. We can see a huge nuclear disc herniation here at the right side, and also moved caudally to the back of the vertebral body of S1. And the X-ray shows no deformity, no spondylolisthesis, and also is also a very young guy. So interlaminar approach, discectomy, it should be the one of the best choice for her. And we can see the fat. She's really a fatty guy. And pre-operative planning for the interlaminar approach. If we have clinical experience for open fenestration and discectomy, we know very clear this part should be our playground for this surgery. And after we remove the caudal part of the lamina, this is L45, and we can go into the canal and to show the transverse nerve from the shoulder part to arrive at the disc. And usually along the concept of EndoSurg, before surgery, we marked the 4 pedicles, these 4 circles, and the midline. And the incision should be along the inner line of the pedicle, and between these 2 pedicles, just in the middle, and along the inner part. From this point, go straight to the to the spine can touch the caudal part of the lamina. And the dilator is helpful for we to recognize, to confirm the anatomy location during this surgery. We can use the grade 1 dilator, pushing down straightly, and use it to feel the laminar margin. And it's very easy to confirm the location because there is a very typical step from the hard lamina, just sliding to downward, and we can see a fall. When we arrive at the interlaminar gap, the yellow ligament located there is soft, and the lamina, the step, we touch the step, we know we got the right position, the right location. And put the U-tube into the soft tissues to touch the lamina, and take an X-ray to make the level confirm. Now, both AP and the lateral is necessary. So by this we can know where our tubes is, and just make sure the correct level, and then we can go on to the next steps without the help of X-ray anymore. The first step should be to perform the laminar exposure. Just like when we perform the open surgeries, we remove the soft tissues at the surface of the lamina, and to show clearly the laminar margin, and in the middle should be the base of the spinous process, and in the outside should be the articular process. This step usually may take 1 or 2 minutes to stop bleeding, to remove the soft tissue. Now, more and more we can see clearly the lamina just here, and along the lamina to the middle line we can see the spinous process. And after we show clearly the lamina, we can use the reamer to perform the fenestration. Usually we only need to cut a half circle, just like this photo shows. I don't need to cut too much lamina, only the caudal part of this location. This part should be at the zone 1 and 2. After we remove these bone structures, we can show clearly a part of the durasac and also the transversing nerve. Also, we need to see these lines. This 5 millimeter, 7 millimeter, and the last one is 9 millimeter. Usually, for China, for Chinese population, usually we need to cut at between the 7 to 9 millimeter is safe and enough to cut the lamina off. Maybe for Europe populations, 9 or more maybe need. I'm not sure. After we cut the lamina, we can see the next layer of ligament flavum. This is the lamina, and this is also some bone structure the deep layer of the lamina, we go on with the reamer. You can see the bone structure is moving. That means the bone have been cut off totally. I just need to remove it. Because there are still yellow ligament, this step is safe for the DuraSurg. See the yellow ligament very clearly. And go on. By now we can use different kind of techniques to open the yellow ligament. And I'm using the reamer to cut off the yellow ligament directly. We can see the epidural fat, and I pull the reamer back. And I use the kerosene to open the, to enlarge the window. Remove enough yellow ligament, we can get a full vision for the structures in the canal. First of all, we can see some epidural fat, and after careful stop bleeding and remove some of the fat, we can see the DuraSurg and also the transversing nerve. This is very, very similar to the open fenestration. Yeah. I think the interlaminar procedure is easier for us to learn if we have open surgical experiences. Now we can see the DuraSurg or the nerve root. Oh yeah, this is the nerve root. The DuraSurg is in the middle. Okay. And I changed the T-tube, take out the reamer and changing the T-tube, and use the T-tube to go in deep into the canal to searching the disc and the herniate and the nerve root. But now we can see this is the nerve root, and here is the DuraSurg. We can decide from this way or this way to go deeply. I push the nerve root from the shoulder part and pull the T-tube into the canal and rotate the T-tube as a nerve root retractor to protect the nerve root. You can see here. Usually we don't rotate the T-tube 180 degrees directly, because that will push the nerve root too hard. We only rotate the 90 degrees, just like this. Use the T-tube to pull the nerve root here, and then we can operate from this part. For this case, from now we can see the nucleus just at this area. This step should be performed very, very carefully. We are dancing just by the nerve roots. Okay, the next step, it should be discectomy. if we have a very good bleeding stop, a very clear vision, this step is easier for us to perform. If there is some bleeding, we cannot see anything, we need to stop. Just go on to stop the bleeding. This is necessary. And after we remove some of the nucleus, the nerve root tend to be more and more loosening. At the beginning, it's very tight, but after we removing some part of the nucleus, the nerve root can be decompressed step by step, and our T tubes can push the nerve root more and more. And finally, after we removed all the nucleus, we need to perform a very careful check. The first, we need to stop all the bleeding. Secondly, we need to make sure the decompression, the discectomy has been performed very enough. There's no nucleus be left. This is the nerve root. This is the dural sac. Yeah. And okay. Sophie, 引流怎么说来着？引流 drainage. Okay, after careful stop all the bleeding and no drainage is need to put in. It's not necessary. Yeah, just like this, we stop all the bleeding point. Yes. When we plan to stop the surgery, we pull the U tubes very slowly, and at every layer, if there is bleeding, we stop it immediately. Just like this, so we can make sure all the there is no bleeding along all the route. And we can see the muscle tissue, they are not be cut off, they are only being splitted. After surgery, they can go back to the nearly normal condition. Oh, okay. Just now I show the surgical details of interlaminar fenestration and discectomy. And this technique can be used to treat the degenerative spinal stenosis cases. We named it the endo-ULBD. Just like this, really the secondary to the hypertrophy of the artificial process, and also the ligament flavum. We can use this ULBD technique. This is a very valuable technique for this kind of cases. After we very familiar with the interlaminar technique, we can try to do this. Yeah, this is the next step. And also, every technique has its own indications and has its own complications. For interlaminar approach, discectomy, there are many kinds of complications, including the perioperative complications and late complications, the dural tear, the nerve root injury, even the caudal equina injury, and the hematoma, and wrong surgical level, and so on. So we should always to perform this kind of surgeries with very, very careful cautions. Thank you. This is thank you for your attention. The best training is still in doing it on your own. And the next week, we will have another live surgery of interlaminar approach. And in the next days, I hope all of you can practice. You will learn it more about this. Thank you.
A very nice lecture. I suggest that everybody copy the PPT back to your own and do the posterior approach decompression according to Dr. Sun's the 6 steps. Yeah, you can do the posterior approach endoscopic surgery. So the next case has been prepared in the operation room, and then let's exchange the screen to the operating room. Okay, it's a case of Let us say goodbye to Professor Sun. He have to on the way to.
Hope to see you again.
Yeah. Firstly, let's talk about this patient's information. Yes. And the moderator of this surgery is Professor Wang Xin. He's from the Lanzhou University, and he is our old friend. He joined all of the international training course, and he's good at English and good at surgery, and he hopes to be the friend of all of you. Yes, let's welcome Professor Wang.
Thank you. So would you please introduce the case first?
Good afternoon. Now I'm make a brief introduction about the surgery patient. Here is the patient history brief. A 25 years old male. His chief complaint is low back pain and both leg pain for 1 month. Which involves the waist bilateral buttocks and lateral signs on both sides. The pain aggravated after walking and standing and relieved when rested. Here is the physical examination. The lumbar 4 and 5 spinal process tenderness is positive. And the patient's left and right straight leg rise 50 degrees is positive. Here is the X-ray. You can see there is no spondylolisthesis in lumbar 4 and 5. Here is a CT scan. In the cross section, we can see there is a lumbar spinal stenosis in lumbar 4 and 5. In this MRI image, there is clear evidence the disc herniation between lumbar 4 and 5. Here's the diagnosis and treatment plan. The patient's preoperative diagnosis is lumbar disc herniation, lumbar 4 and 5, lumbar spinal stenosis, lumbar 4 and 5. The surgical treatment is endo-ULBDD.
The systems used is EndoSurg Plus. Okay, that's all. Thank you.
So group 2 go to operation room. Okay. 把镜头给切到那个手术室。Group 2。
已经上去了，对。没事，你坐。
转不到手术室。So we can enjoy the surgery now. So 这是在谁做手术？周老师。周老师。So Dr. Zhou, would you please give us a brief introduction? 12 o'clock, 6 o'clock, where we are now. Thank you. 请介绍一下我们现在的6点、12点都是病人的什么方位，从哪侧的入路？谢谢。能听到吗？是不是上面听不到？我感到上面听不到，好像。It should be a surgeon stand on the right side of the patient, and 12 o'clock is the middle line, 6 o'clock is the lateral side, 9 o'clock is cranial, 3 o'clock is caudal. 好，现在可以听到了。可以。请帮我们介绍一下现在就是手术的这个头端、尾端。
Professor Wang.
Okay.
Can you hear me?
Yes, we can hear you.
Okay, I will start the server now. I can hear you. Now I will explain something for all of you. 3 o'clock, that's the caudal side. 6 o'clock, that's the ventral side. 9 o'clock, that's the cranial side. And 12 o'clock, that's the dorsal side. So now you can pay attention to the X-ray from the AP. I always use the AP X-ray to check the duty level. For this patient, it's L45. I don't always use the lateral image, but because it's this training course, I will check it again. I should make sure the position of the UT tube. Now you can see how to use U tube and T tube and how to separate, how to look it together. Here, this side, you can see this is U tube, and this is the length of L4. Here is the T tube. So I always do it like this to make a new space. There's no soft tissue here, no bleeding. And I can see this is the length, this is the SH here. And now I will explore the length of L5. Here you can see. So that's like a V point, the same as the cervical keyhole technique here. This is the length of L5. So you can see the length, the window, and the length of L4. For this patient, my plan, because that's not only the central base condition, there's also the ligament level. There's also the stenosis about the central canal. So I will do it like first the URBD, then I will take the disc out. So I finish my explanation. Watching, you can go on.
Okay, thanks for your brief introduction. We can see you very clearly. First, Dr. Zhou will use the reamer to cut the bones. First is anti-clockwise. We can lock the reamer at here, not wheel slipper. Then we will clockwise over and over again. We can see the third line. It's our indication not too deep. And you can see the bones swing with the reamer, clock, and anti-clockwise. From right side, the video, we can see Dr. Joe use his hand, put it out together.
So the first reamer is very important for the posterior approach. So I always select the point is close to the conjunction of the lemma and the RHP. Not always, you can see this is RHP, and this is a ligament level. So it's easy to break down the bone graft.
So I repeat again, Dr. Zhou's side is very important for first reamer. You found the junction between the IAP and the lower part of the lamina. That's our first reaming location.
So from now on, we always use anatomy as navigation to guide us to do the next step. It's very important. And I also like tell you how to use the tube. It's very important. Do it like this one. This one is like another assistant to separate the soft tissue.
So he separated T-tube and the U-tube, found a very good space. Let us see more clear like this. Fix the U-tube and turn the T-tube like the retractor. Make our vision more clearly.
After the first reamer, I will first check the position. Is it correct or not? Then I will do the next reaming. Not always reaming. We should ream and check. Even useful for the beginner.
So reaming the bones again upwards to the cranial side. At last, we hope to find the attachment of the ligament on the lamina.
For this patient, it's a young guy, not an old guy. So I will try to protect the facet joint.
So here, Dr. Jones protect the capsule very careful because the patient is just 26 years old.
So for this patient, if you use the lateral transforming approach, you can only take the stitch out. You cannot decompress the sitting ligament level. So that's maybe 10 years ago, I will use the lateral approach. But now I will try to use the posterior approach. We call it URBD. So that's my philosophy. I add another D to for URBD and add a D. We call it URBD for the bilateral discectomy.
So we have reamed the bone 3 times. You can see the flavor very clearly. Maybe it's still not enough, so we will reaming again upwards to the cranial side.
put this is younger, but its quality is not so good. So I can easily use the river. So we should always monitor the ball structure. Maybe here you can see I will monitor the 3 to 5, 6 o'clock. Here that's the space. We should monitor to judge how far we from the ligament level. And also the teeth. You should know the teeth. Where is it?
Some doctors may be worried about the safety of the reamer, but doctors he observed and monitored the tooth of the reamer. We can see the tooth very clearly. So just float on the superior of the flavor. So it's safe. You will not damage the important structures like things like.
Another thing for this patient, the lymph level is not so thick. So I should take care. If not, the reamer will directly enter into the spinal canal and destroy the root. So you should pay attention to this thing.
He tried to protect the facet joint as soon as possible because he's a young patient. But for elderly patient, Dr. will take more bones one time. Layer by layer. We call slice by slice.
So I will suggest for the beginner, you should do it like this, not always verbal growth, piece by piece. You can see everything clean. So that always bleeding. Really for me, if you want, you can stop any bleeding. If you, so it's a habit. It's not a technique. It's a good habit for always stop bleeding.
Most bleeding at this stage coming from the bones. So he has a very good habit. Found the bleeding, stop it, and make your vision clearly. So we still need to cut more bones upwards. Try to find the attachment of the ligament on the F4 lamina.
Because a young guy and not an old guy, so I will take care to cut. Enough is good. I don't want to cut much more. That's a balance. So you can see I always root the U tube, the outer tube to compress the soft tissue. give me much more space to use the ribbon. So this also you should know how to use your assistant during the operation.
So the UT tube like retractor when we're doing open surgery. So almost the same procedure.
You can see from here, we can get to the technique about the previous slide about the linear level. Here is the attachment about the, here you can see very only small here. I will use the plastic board to do it again. That's okay. So I always cut this side. This is the over top technique. This is the spinal process of L4. So always root your left hand to monitor this side. So make sure every side is safe. So we always break down the bone graft, not always reading.
So Dr. Zhou is doing the resection of the spinous process. Look at the right side. He tilt the tube a little, maybe 20 or 30 degrees. This step we called over the top.
So for beginner, you should know how to use ribbon and how to control the whole system, and always make the stabilization, and always rotate the whole system to get a good position to catch the ball like up then out. So it's very very important steps. You can see the abdominal fat. Here we get to the attachment. You can see here. So that's the middle line, and also you can see here. So for this surgery, I use a very small incision. I think give me a little torsion. I cannot move the system very frequently because the incision is a bit smaller, less than 1 centimeter. I think it's not a good selection. So for beginners, you should take pay attention every detail. Any steps you should pay attention. So this is the old top technique. You can see this is the opposite side. This is the spinal process of L4. So we always adjust the whole system. Always rotate your left hand to monitor the opposite side. So it always breaks down the bone graft, the bone structure, not always ringing.
So in case of injuring the dural sac, when we remain, we should notice or monitor the tree fence teeth. Not cut into the yellow ligament.
So you can see here, this is the opposite side. Also, there's a venous artery here. I was opening firstly. Okay. So the other side, for this side, I have cut the bone out. Then I will use first report to do it again. So now the caudal side I can finish. Then I will cut that's the preview. This is the caudal side.
So we have finished from the 6 o'clock. I mean the lateral side of the yellow ligament attachment and the spinal process and the contralateral side for L4. Now Dr. Zhou is moving his endoscope to the caudal side to find.
So you see, this is the IEP, this is the SEP here. There's a joint here. So there's a lemon here. We are familiar, very familiar to all the anatomy.
Just now, the direction is clockwise. Now we should anti-clockwise. Cut the SAP of L5 and to the middle line, spinal process, and the contralateral side. The same procedure. From 3 to 6 o'clock is the upper edge of the L5 lamina. L5 lamina.
So this side, this lemma is very dangerous because the lamina is very thin, and not very thick. So the attachment for here is very small. So you should know how to bring down the bone here. You can see it here. So for this side, it's easy to get close to the attachment. So you should know anatomy about the ligament level here.
Sometimes the flavor will let our vision not clearly, so we can use tree fine to cut some ligament. Just now, Dr. Zhou has exposed the attachment of the yellow ligament on the caudal side.
Here, I will never use the rimmer to directly cut the ligament fragment. I only use the rimmer to deal with the superficial side of the ligament fragment. So you can see this is the middle line of the ligament fragment. From here, we can enter into the channel, spinal channel.
When you see this gap between the ligament, you know you are in the middle part of the spinal canal. So here is the spinal process. Resect more bones to the caudal side. This step a little dangerous, so you should control your reamer not too deep. Actually, you can hold your endoscope, use your left hand, float on the superior of the flavor.
So from the beginning, I have told everybody. So this one is not old lady. So the spinal canal is not very serious, not very stenosis. So the ligament level is thickening, but not the very thickening. So you should take care. You can see this side. If you do it like this, you will make a bigger.
So we have arrived to the contralateral side. Look at the right side. Dr. Joe's tilt the endoscope more big angle.
So because we are also neurosurgeon or spine surgeon, we should learn how to control the whole system. You can see very close to the canal. We will stop and bring down the ball. Not always reading. I have told you for several times. It's a rimmer, but it cannot be always used as a rimmer. Always use it like a separation. So here we did for the opposite side. Here we did not enough. I will use the fast before. I will do it a bit more. So now you can see I will only rotate my left side hand to monitor this side, nitro.
So you can rotate your endoscope for better vision.
So I will finish the laminectomy, but this side video is not enough. So I will cut the my side. This is REP. Below that's SEP.
So he thinks the space is not enough, so cut more bones. On the top is the IAP, and the deep layer is IAP. On the bottom, we can see at 6 o'clock is the IAP, SAP, sorry. Here is also the lateral attachment of the yellow ligament. A little IAP, Dr. George is rimming.
Here you can use the high zebra accuracy, not always use a rimmer because I'm good at rimming, so I will always use the rimmer to cut the ball. It's faster.
If you are good at using rimmer, you will get a high efficiency when you're recutting bones.
剃头。So now I will use the two tubes together. So this is the T-tube. Here you can see. So now I will lock it together, make it like one tube.
The bone resection is finished, and doctor use UT tube embrace it, not separate. So we get more retraction. The next step is take out the yellow ligament.
So when you will do the further to decompressing for the ligament level, you should stop any bleeding. Try to stop any bleeding. For the first surgery, I know there's some bleeding going.
If you don't want to use reamer, you can use high-bit spur. Look at right side on the corner. Dr. said use his thumb to control the depth of the spur burr. And swing the endoscope, remove more bones.
So it's an old lady. I mean, you do much for reading, but it's here is a midline reader. So I will try to protect anything. So aiming for the upper level about the lumbar surfaces, I would suggest always use much more high-speed board, not always use reamer, because sometimes they will cut the facet joints.
Now we can use kerosene to cut attachment of the yellow ligament and bones. On the bottom is the epidural fight.
You can see I will only cut it down, not always take it out, because I want to see the whole hot part together to take it out. Now my left side, my left hand, each finger will cooperate to do the surgery. My left hand and my right hand, you should know how to use your two hands to take everything together. I always root my left hand to get a good direction. Another thing you should know, this EndoSurg Plus system is a medium-sized endoscope. So I like it very, very much because I can see everything. I am very close to the nerve root. I see everything in detail. Not a big one, not a small one. So you can see, I can see the left side of the dura. So I can use this system to do any kind of decompression, maybe for thoracic, and for cervical.
When we're using kerosene, if you cut the yellow ligament piece by piece, it will waste a lot of time. So Dr. Zhou is trying to cutting the attachment of the yellow ligament to the lateral side. As we can see, the cranial side, we have cut the attachment. And later, he will cut the caudal side of the yellow ligament. Then take the yellow ligament, the whole piece. It can save time.
This is the code side.
Still use hybrid burr to cut the bones.
I will start from the midline. I think it's very easy to insert the curvature. Not always from the midline, it depends, different case. So a very important thing is how to use the tube and the retractor. So we use the unifocal endoscope. We think it not only one surgeon to do the surgery. So any tube can do it like a think tank to help us do surgery. You should know how to use it better.包括那个交易培训部，那个叫会议，知道吧？还是或者问那个参展，因为呢，我那个几点到最晚几点到？是那个有个教师节的那个评优部啊，需要我赶紧去。
Never mind. Dr. Zhou had a lot of task days. You know, tomorrow is the Teacher's Day for Chinese teacher. Even you are middle school or in university school, we always, including me, I will give my teachers a flower. Yeah. So Dr. Zhou has an important meeting for another branch of the hospital. So he's trying to do the surgery, perfect surgery. Yes, yeah. But Teacher's Day is important. You are my teacher.
It's our pleasure.
Yes. So we are cutting the attachment of the yellow ligament attached to the up part of the L5 lamina.
You can see because the ligament is very strong for this patient. I have taken the outside, the part out, but I don't want to do this. I want to take the whole part together. But it doesn't matter.
So for me, I prefer use kerosene to cut yellow ligament. I believe it's more safer. When we give a good decompression, maybe some bleeding.
So we make the surgery, we always fix this condition, much more bleeding, suddenly. So now you became a hunter. You should know where to check where the bleeding it is. It's very important. Not you can see I have checked it. Just here, so I can stop the bleeding very fast. Not always move.说是体力单，他不允许的话，我就为他去把这变动。我可能是吧？哎呦，有什么想？
We got more room, more space, so cut more bones. Still on the lighter side of the attachment of yellow ligament. We almost see the border of the thecocyte, so resect more bones, get enough space, we can release the nerve root, let it freely float. And later, when we take the herniated disc, it is more easy. Actually, 6 o'clock is the disc, now it's a probe. The probe is touching the surface of the annulus. We can see the pulsating thecocyte.
So I can finish this side. We can see the edge of the nerve root. We can see the disc. We can see the this is the SAP, the joint. I think it's enough for this side. So I will do the opposite side here, also from the midline to check it again.
No, we have finished the simple side of the yellow ligament decompression. Now we move to the contralateral side to find the contralateral side disc. It appears the bone resection is not enough, so we use high-speed burr to cut more bones.
For this side, before I will use half teeth about the renal. But I think the high-speed burr is safe. It's very It's a bit easier for the beginner to do these steps. So I will suggest that because we can see the ligament level here is it's also very like safer. Leave the ligament here. I can use the hard paper very safely.
Another choice is using half-tooth reamer. Generally speaking, we have two kinds of reamer. One is the whole teeth, another is half teeth. Half teeth means you can put the teeth on the contralateral side, IAP or SAP. But the other part means no teeth. So even you cut the yellow ligament, it is still safe.
So because here you can only judge the position and direction, use the anatomy. So I will not only do one side or one place. I will always change the direction, change the position to check the whole direction. But always cut the one side always. Always like from cranial to caudal, or I will change from caudal to cranial because I want to check everything, get whole information about the opposite side.
Take the left ligament. Sometimes Dr. Joe will turn the endoscope anti-clockwise. So now the 12 o'clock is caudal. 6 o'clock is cranial. 9 o'clock is 9 o'clock. Now he is turned again. So 9 o'clock is the contralateral side. You can look at the upright triangle. The doctor turned endoscopic.
From this side, you can see the anatomy about about the ligament level attachment to the ligament. You can see very clearly. Okay, you can see the details about the attachment anatomy about the ligament level with the lamina.
So using kerosene to remove more inner ligament contralateral side.
So another key point is equipment. So this currency is very powerful, very strong. Even for the forceps, we can use any equipment to take the ball, to cut the ball. I think this is why we can use this equipment to do this surgery. I think it not only because of the labor, it's because of the whole system. So I like this system very much because it's powerful. Any equipment is very, very powerful. So this is a contralateral IEP.
Dr. Joe spent sometimes for resecting bones because the patient is 25 years old. He wants to protect the fifth joint. So now, like for elderly people, he take more bones on the contralateral side. We can see the contralateral side, the border of the dural but it looks like space is not enough, so we need to take more yellow ligament contralateral side. You can use kerosene, curved forceps, or any kind of instrument you like.
You can see the capsule of the cell jet here. This is the SCG of the contralateral. We can take this side, this ligament from out. I can finish the bone. So I will do the disectomy.
So
From the side, you can see the pedicle now.
Pedicle on the 12 o'clock, right?
Here, there's the lower root.
So we can see the border of the thecocyte.
I will do it from this side to see everything clear.
So now the direction is 12 o'clock is caudal side, 9 o'clock is contralateral side, 6 o'clock is cranial side.
So why I do this surgery? You can see from the footsteps, you can see the ligament level is also very sticky. So which the lateral extent is also very narrow. So our solution for this patient is, I think, is correct.
Yes.
Yeah.
More clearly.
Yeah. So because there's an epidural effect, so we always make you cannot see everything clear. You should know how to use a tube to recheck and recheck the fat in the soft tissue. All in the root your left hand. Because I always use my left hand to control the system. Somebody may use the right hand, very better.
We can see the gap between the SAP, IEP, and the DuraSec border on the contralateral side. The small piece of yellow ligament.
Here is the pedicle. Here is the pedicle. Okay. So,
Sometimes when we need to confirm if we can get good decompression on the contralateral side, we usually use probe to touch the pedicle, the medial wall of the pedicle. That's actually it's enough. Like when we performing open surgery, actually we do not open all of the lamina, especially contralateral side. So just remove the yellow ligament, we can get a good decompression.
So you can see the number here, only a tiny limit from here until on down.
From 12 o'clock to 6 o'clock is duropsych.
我接着，但是我第一个，我手上我有一个耳机接不上，接着有扬声器。
Clean more soft tissues, we can have a better vision.
喂，不行，我这边有个扬声器。
Now we use YouTube, we rotate and push down and push the duropsych and the nerve root. Now in the middle of the vision is a herniated disc. Just rotate and push slightly, push the duropsych to the midline. Nine o'clock is the cranial side. 3 o'clock is caudal side, 12 o'clock is the midline, 6 o'clock is lateral side. Just punch, make a hole on the annulus. You can see the herniated disc. Use YouTube to squeeze the disc. Use forceps to take the disc out. Let's take a look at the right angle. The endoscope is upright. Still more disc still here.
Morning. Morning.
So use curved forceps, straight forceps.
你9点播不是？9点播不是？9点播你们正常播不就行了吗？正常做10点多不就做完了吗？
The patient have two side symptoms. So ULBDD actually is good indication for this kind of patients.
明天都是谁做手术啊？明天都是谁做手术啊？马主任不做吗？为什么？原来不是排的有他吗？
So at this stage, we needn't hurry up. Take the herniated disc piece by piece. It will spend some time. It deserves to spend some time at here.
放第二个。把它放最后一个，我看会儿没人，下午我过来做。那也得做ULBD啊。Because it's a young guy, the disc is not so degenerated, so we should
Look at the right middle part of the fluoroscopy X-ray, AP view, lateral view. If you doing the surgery over 10 or 20 cases, actually the lateral side is not necessary. It just makes sure your tube is parallel the intervertebral disc. But before surgery, you can see the X-ray, lateral and AP view, and adjust the angle of the surgical table.
So I will.
Okay, we got to the contralateral side and expose the contralateral side disc. There's some fat in here.
I will check. If it's not so serious, I will leave it alone. I will not do.
We use the tip of the U-tube.
哎，那个王鑫听不到我说话了，是吧，王鑫啊？他听不到我说话了，早都听不到我说话了。我在自言自语，我在。之前的，他早就听不见我说话了，我发现，他不管我了呀。王鑫。
Okay, so turn the U-tube.
Professor Wang， 啊，中英文都不回答我，那肯定是听不见了呀。
The annulus is exposed.
王鑫，你看他不理我了。对，他都听不见我了。他这样，他没听见我说话呀。
Actually, just now we have arrived at the middle line of the spinal canal. use the tip of the tube, protect the durocyc and the root. We have some doctors. Yes.
Before we cannot hear you. I can hear you, but you cannot hear me.
We can hear you. You also can hear us.
No, yes. I will teach you to the dissecting of the continental side.
Yes. Use punch to cut the annulus fibrosis and use tube to protect the durocyc and the root. The same procedure, like the same side, use forceps to take out the herniated disc.
So this technique, we first take it up from me because in my daily clinic time, I will face much more complex cases like this one. We should do the bilateral dissectomy and also the spinal canal, the central disconnection, central spinal canal stenosis. So I always, why I can use this technique because the size of endoscope is very suitable, not very small, not very big one. So I can, you can see my left hand how to control the whole system. So the U2 tube together and the tip of the tube, we can use it to retract the lymph node slightly. Like this, you can see everything clean.
Yes, we can see Dr. Joe's position, hand position. He used left fingers touch the end of the T and U tube and make the whole system stable. When he used kerosene or high-speed burr, as we can see, he still use his thumb to control the system. So every fingers in Dr. Joe's all works. So
for several cases, I use nerve root monitoring. Now I never use it because I can control the whole system and slightly retract the nerve root, not always retract it. So I think it's safe. But for the beginner, I think you should take much more practice. You can see I will lose it. You can see that's a nerve root. I will check it again.
Dr. Joe said about the electrophysiology monitoring. If you are a beginner for the first several cases, this kind of monitoring is effective. But after several cases, you will be good at the using of this kind of instrument, endoscope. You know, you will not compress the durocyc and nerve root, so it's safe. You don't need to doing monitoring. Actually, another choice, if you are not good at ULBDD, you can do this kind of surgery, both sides. I mean, 2 incisions, left and right. It's still safe. And ULBD and ULBDD actually is the basement of the T-leaf under endoscopy. Actually, the difficulties, ULBD and ULBDD is bigger than fusion, doing fusion. Doing fusion actually is safe. Like when we doing transforaminal approach, cut the SAP and the IAP and found the disc and clean the disc and put the interbody fusion in here. The next step, okay.
My side.
Yes.
我让等我收场，我要去
好
，OK，
OK
这样就是错了，
OK
让他最后 check 一下，
好 Yes
接下面。最后要整个看一下啊，
Actually, we almost finished the surgery. And the last step is also important. Check if we still have some disc fragment in here, in case in caries. Now we can see the contralateral side, the disc, and rotate the tube. Push the DuraSyc into the middle side, in the middle. My experience is when I use tube to push the DuraSyc, I will not keep the tube at here last 3 minutes. If over 3 minutes, I will release the nerve. I still worry about maybe the patient's foot job, maybe. So 3 minutes is my time. It depends different doctors' experience and habit. Here is the same side, I mean the right side.
Okay, Professor Wang, I think the operation could be finished.
Stop bleeding. Some bleeding come from the bones, some from the epidural veins. Here is from the bones. For some osteoporosis patient, it is still difficult to stop bleeding very completely. But if under the saline pressure, I mean water pressure, the bleeding is stopped, you don't worry about the bleeding after several days. Some doctor will put a drainage in here, but I don't think it's necessary. So another tips for doctors or from me, when I pull out the endoscope, I will not use very hard effort to squeeze the saline in here. Actually, the saline is kind of pressure, can stop bleeding. So I have done almost 1,000 cases. I never use one case using drainage, so I think it's safe. In the next few days, some doctors will share the tips or experience on bleeding. Some doctors they like use tranexamic acid, but some doctors they don't like to use it. So it still depends. For some doctors performing open surgery, they told me I never use tranexamic acid. I think it's dangerous. From some papers published on some magazines, I noticed they have reported when they use the tranexamic acid, the patient have very bad complications. But for endoscopic surgery, I still think it's safe. But if the DuraSyc tearing, you maybe not good choice. So all of the compression is completed. The herniated disc is removed. Here, some bleeding from muscles. Here is a vessel, you can see. Small artery. So, Dr. Chu, are you going to finish the surgery?
Okay.
Okay, good job. Well done. Thank you. Thank you very much.
Thank you, Professor Wang. Okay.
So, about case, any question or comments? So later, Dr. Xu will give us a lecture about the posterior ULBD. If you still have question, you can ask Dr. Xu. He will give us a very detailed introduction how to do this kind of a surgery. If you have any question, we can have a communication. Maybe the afternoon, after lunch, everyone have a sleepy. We can stand up and we get some work around. And if you have no any question, we can have a break. Okay, and we wait another case and another lecture. Thank you, everyone.
这个视频大家觉得是不是理解这个 那他讲完了没？那就请另外一个吧，里面。
然后那边弄好我赶紧下去。
It's a lecture.
您介绍一下，先把您介绍一下。OK。进来。到楼哦，已经到楼上去了。OK， 那就开始吗 ？OK， 好。So it's our lecture time. Let's welcome the Dr. Xu Duorong. Dr. Xu give us the lecture. The topic is clinical application of endo-ULBD in lumbar degenerative disease. Actually, Dr. Xu performed a lot of endoscopic surgery and doing ULBD, PLD, and fusion. So he will give us a lecture, and after lecture, if we still have question, we can very good talk. So, Dr. Xu, please.
Thank you for Professor Wang's introduction. I'm Dr. Xu from the affiliated hospital of Qingdao University, and now let's talk about the clinical complication of endo-ULBD in lumbar degenerative disease. ULBD, which means unilateral laminectomy for bilateral decompression. In 2002, Professor Bernard performed it on human cadaver model with MED. During the operation, he used the high-speed drill and kerosene ruler to remove the bone, just like this picture showed. And he published the paper introduced this kind of surgery. In 2007, Professor Kehoe reported the MED with assisted ULBD on human body. At the same year, Professor Rutten reported the interlaminar approach discectomy of intervertebral disc with endoscope. And he also pointed out that the endoscopic decompression by interlaminar approach is suitable for 70% patients. This is the theoretical basis for endoscopic ULBD. However, if you want to perform your ULBD excellently, in addition to perfect technology and conception, the tool is also very important. For me, I think EndoSurg Plus is the most appropriate tool. The median channel could provide high efficiency for bone resection and flexible enough to accomplish contralateral rhesus decompression. We can use reamer, use high-speed drill and kerosene ruler to remove the bone. The whole operation can be finished just like an open surgery. Not only the surgical view, but also the procedure and the conception, just like the operation just finished. There are some key points to perform the ULBD, including how to improve the efficiency and how to protect the nerve, the root, and keep safety, and especially the contralateral decompression, and how to control bleeding during the operation. Now I will take this case for example, to introduce the basic procedures and share my experience of endo-ULBD. This is a 51-year-old male patient. He suffered from low back pain with lower limb pain for 3 months and aggravated for 1 month. The symptoms mainly affect the right bottom and the lateral side of the right side. We can see from the X-ray film, there was no obvious instability of lumbar spine. And this is the CT scan, no spondylolisthesis. The CT scan showed there was a lumbar spinal stenosis of L4 to L5. This is the MR scan. And also, we can see from it's the L4 to L5 lumbar spinal stenosis. For the incision, we always choose a transverse cut, and the length is about 8 to 10 millimeter. If you want to perform multiple segment ULBD, we can confirm the incision in one time. The incision should be on the inner upper edge of the inferior pedicle by AP film. Just here. And before we take the AP film, we should pay attention to the patient's position. The affected vertebral space should be vertical to the ground, just showed in this picture. The intervertebral space should be vertical to the ground. And after connecting the endoscope, first we should expose the L4 laminar, IAP, interlaminar window, which means the waypoint, and the L5 laminar clearly. This is the L5 laminar, this is the interlaminar window, and this is the L4 IAP, which the waypoint just showed in this picture. And the first reaming should located on the distal area of L4AP. It's here. Below it, there is the SAP, so you can don't worry about the reamer may hurt the nerve roots. Then we remove the tip of IAP by the second reaming. After that, we can see, after removing the tip of IAP, we can see this is the L5 laminar and this is the L5 SAP. We see it again. Interlaminar space, L5 laminar, and L5 SAP. Then continue reaming along with L4 laminar until to the cranial attaching point of the flyworm ligament. Keep reaming until we can expose the attaching point of flyworm ligament. At this point, we can see from the video, after where there may be a bleeding from the intravenous plexus in the spinal canal. It's normal because after you remove the ligament, the change of the pressure may lead to bleeding. Don't worry, we just use the radio frequency to stop it. You can see from the video. This is the bleeding, and we can just stop it with the radio frequency. Also, there is a bleeding from the bone surface. Just stop it. This is the attaching point of flyworm ligament on the cranial. The next step is over top. We remove the base of spinous process. Also with the reamer, just like the video. Yeah, it's broken. And after that, the spinal canal. After that, we can have enough space to get to the contralateral side and remove the contralateral L4 laminar. Only after we remove the base of spinous process, we can have enough space. The tube could get to the contralateral side. Then continue reaming of the contralateral L4 IAP. This part. After removing the contralateral L4AP, we can back to the ipsilateral side to perform L5 laminoplasty. After we remove it here, and we can back to ipsilateral side to remove the L5 laminectomy plasty. Here we can also use the high-speed drill and the kerosene because it may be more safe. Also, we can still use the reamer. Just like last operation, Professor Zhu used the high-speed drill to deal with this part. We can see the video again. This is the use the reamer to remove this part. At last, we broke the fragment. Yeah, just like this. Also, for me, at this time, I would like to remove the medial margin of the ipsilateral L5 SAP. This part, because I think it may be easier to expose the lateral side of the root after I remove it. Then remove the base of spinous process here over the top from the caudal side. At this time, we can see the dura is here. And when we're using the reamer, you should keep the direction to the bone surface with the teeth to prevent the teeth hurt the dura. Okay, then we continue to remove the contralateral L5 laminar. During the process, it's here. During that process, there may be intravenous bleeding. We can see after we expose the dura, there is blood vessels on the surface of the dura. I would like to pre-hemostasis of it. Just to use the frequency. And this video, we can see. In this video, I rotate the tip of the tube to blend separate the flatworm ligament and remove it in one whole piece. I just rotate the tip of the tube to separate the ligament. From the cranial to caudal. Then I can take it in a whole piece. Then I will use the half-teeth reamer to remove the contralateral laminar and expose the attaching point of contralateral flatworm ligament. That's here. Now I'm using the half-teeth reamer because in this part, the dura sac is exposed. If I still use the four-tooth reamer, it may hurt the dura. So at this site, the half-teeth reamer is a perfect tool. Here it's exposed. Continue, use the half-teeth reamer to remove the laminar and the IAP. It's broken. Then remove the medial margin of the contralateral L4 IAP and expose the contralateral L5 SAP. After that, use the half-teeth reamer to expose the separated caudal attachment of the flatworm ligament on contralateral side. Just like the cranial side, we also use the half-teeth to remove the caudal side, caudal attachment of flatworm ligament. Then also we can take out the flatworm ligament in a whole piece. This is we remove the contralateral L5 SAP with half-teeth reamer. After this reamer, the contralateral side flatworm ligament, the cranial endpoint, the caudal endpoint, and the lateral endpoint all separated. Then I can take the rest contralateral flavum ligament in one piece, just like this. And after that, the final check. You can see this is the dural side, and this is ipsilateral side, and this is nerve root. This is the disc, nerve root, and over top, contralateral side. Rotate the tube, protect the nerve root, disc, and the contralateral side nerve root. Is here. The decompression is completely. For the operation, for the last operation, Professor Zhu showed he also resected the intervertebral disc on this basis, and this is the post-operative scan, which shows the basic joint without destroy. Basic joint. Is the 3D making structure, and this is the amount compression. The compression is that. Also, we perform the large consignments of lumbar spine uses with regard to it. This is the case with 2 segments of pinosis, and this is the case with 3 segments. We perform this operation. And this operation is the hours. This is the post-operative unit. We also proposed the PDD that shows the biophysical operation for the treatment of central lumbar spine stenosis combined with the central lumbar distribution. Achieve 360 degree compression with the paper published. And in conclusion, I think there are 2 key points from the right. First, it's adequate hemostasis and clear view of our central field. For the operation, we should pay attention to population control drugs and control blood pressure during the surgery. Besides, we should adequate lateral back to ensure operation fix. We can deliver the clear and everything to the phone and achieve that. Thank you very much.
So, do you have any question? Last operation, we observed the ULBDD. So now the Dr. Shiko asked ULBD. So actually almost the same operation, but the ULBDD, you will cope with the contralateral side disc. So for the lecturer, Dr. Xu, who have question? Yeah, yes.
How do you estimate how far you have to go rostrally and caudally? I mean, to have a complete decompression. Do you check it with the X-rays? If you have enough decompression rostrocaudally?
That's a good question. And also, you want to achieve the effect conversion to the final and the total, also to the lateral. You have to reach the attaching point of the ring, which means you have to remove the ring from the top to the bottom, and also to the lateral from this side to the other side.
Okay, who have a question? Actually, I have. I still have, I always do the UABD, but in my hospital, some younger doctors, they also told me they worry about when we performing the contralateral side decompression. Maybe the tube will compress the dual sac or nerve root. Very little cases, the patient after come back the bed, the patient will have the full job. So how to prevent the situation? Could you please share the very good experience for us? Thank you.
First, you should pay attention to the, you should know exactly where is the nerve. And during that process, you perform the laminoplasty or to remove the elements. You should know the tool and not push or compress the nerve. This is it's easy to see, but it's very difficult to achieve do it. Because when you massively, the bleeding may tell your sight, of your view, and at this time you don't know where you are, and you don't know where is the nerve. So this is a little tip. You have to perform enough endo down the interlaminar closure of the discrimination. After you have practiced enough, you can try the UABD. It's not so easy. Before you can do it, you have much experience or you are skilled the simple interlaminar operation. And another one, especially Professor Wang said, how to deal with the contralateral side. Enough space. You have to remove enough contralateral lambda. You have to remove enough contralateral IAP, and sometimes you should remove the contralateral part of the contralateral SAP. Only after that, you can get enough space to insert your tube to the other side. And you can get enough space to rotate it, you can have enough space to expose So if you don't have enough sections of the lambda or IAP, it is difficult. It is impossible for you to achieve that compression.
Okay, thanks for sharing. If anyone don't have any question, Dr. Xu still has another case for us for fusion. So he will do a lot of preparation. So thank you again. Thank you. Dr. Sun will give us a brief introduction of next case for the fusion.
Hello everyone.
Hello everyone, it's so honored to be here and present patient information about case 3. This is a 73-year-old female and her chief complaints are low back pain for 2 years and post leg pain for 2 months. And the history of present disease is that the symptom ranges mainly from the posterior lateral thigh and the posterior lateral grasp to the back of the foot. The pain aggravated after walking and standing. and relieved when rested. The physical examination showed that the patient had L4 and 5 spinal process tenderness. We then imagined the patient accordingly. The pre-operative X-ray showed that the patient had sleeper instability in L4 and 5. The pre-operative CT scan also showed the same changes as X-ray, and the pre-operative magnetic resonance imaging further confirmed the spondylolisthesis. Finally, combined with the above imaging, we diagnosed that the patient had the first degree spondylolisthesis in L4, and we want to do the operation with endoscopic transformational lumbar interbody fusion through EndoSurg Plus system. That's all. Thank you.
Thank you for introduction. And for this case, anyone, our doctors have another suggestion for some spondylolisthesis. Some doctors will choose no fusion under endoscopic surgery. They think the first grade spondylolisthesis, they don't think it is a problem because they don't touch the disc, just to make a dorsal decompression. So I would like to hear our doctors be seated here. Do you think fusion is the best choice, or you have another choice? Who have different opinions? We have
There's a communication walking major sort of different. He has back pain and stomach pain.
But the SLR is negative. Like a risk test is negative. Spondylolisthesis and stenosis actually. Okay. But actually in our hospital it depends. Some doctors they still insist just doing the decompression on the dorsal side decompression. And they observed almost 50 cases. The outcomes almost good. Still just one case after the just endoscopic decompression, no fusion. The outcome is not good, but the other cases, the outcome is great. So I think we need to still observe more cases to see if for spondylosis grade 1, we can just do decompression, no fusion. So they are doing preparation. Today use electric magnificent navigation. With the preparation need sometimes. The navigation's brand name is Filgen. In our hospital, we don't have navigation, but my leader, our hospital president, they want to buy the robot. It's expensive. He told me how many years you should pay for the machine. I told him maybe when I retired, I can pay it all. The dressing is waterproof. Next years, this kind of dressing are not available in our hospital because the fees cannot be paid by the patients. So the hospital told us, even you could not let your patients pay the fees, then your doctors pay the fees. Doctor said, no, I don't want to pay the fees, so we cannot use this kind of dressing. It's very good, waterproofing. Very sticky on the fall side. Navigation has very well for incision design. In the past several years, when I do infusion, I will use 5 incision, 5 particles. 5 particle and another the 5th incision for the fusion. But now we design the decision, we can use for L5S1, the 2 incision is okay because we can, L5S1, they are closer, they are the distance closer. But for L4, L5, just you need 4 incision. You can design the incision when you're doing the TLIF. You can design the same channel with the L5 particle channel. Later we can see how they design the incision. For bleeding control, just like Dr. Xu said, he used epinephrine 1 milligram plus into 500 milliliters saline, and just use 10 milliliters for 1 segment. And in the operation, he used tranexamic acid for 2 grams plus 100 dextrose, 5% dextrose. And he also, he's going to tell the anesthesiologist, you should help me to control the blood pressure, not over 110. Last week, I do a surgery. The patient have high blood pressure, 160. I told the anesthesiologist, I hope you can control the pressure. But he told me the patient, even he takes some medicine, but the blood pressure is still high. So that day, my probe started to work. So I performing a very tough surgery on the last week. Even the outcome is good, but the whole course led me with almost 1.5 hours to stop bleeding. Yes, his injection, the epinephrine, his navigation rod, the first rod, and put the sensor in it. Here the pins is, we can put in the crest, iliac crest. the second rod to help to fix the sensor. Hello? Can you hear me?能听到吗？能听到吗？手术室听不到是吧？现在？哦，正在带 ，OK。Here is putting the electromagnetic pad on the two sides of the patient. Here, the pad, when you put it here, do not move the patient. He will use C-arm, takes X-ray, AP, and lateral. Put the big sensor into the F4, F5. You can see a lot of hole in it. It's loading CT. It's loading CT. The CT has copied into the Fielgen machine yesterday. If you're familiar with the navigation process, you can finish this step within 30 minutes. Yes, this is a CT scan has stored in the machine yesterday. Here shows the patient position and the C-arm. You just follow the instruction. We can see the patient localizer is not available, so they are adjusting the navigation. Sometimes the sensor doesn't work. You can choose new one. Okay, the light is turning green. It works. It's APV. We can see a lot of holes on the maple bridge, on the sensor in the middle. So just make sure all of the holes include the F4, L5 segment. If we finish the X-ray, we can transfer the picture, decomp, and just use a U-disc and put it into the Fielgen machine. They will automatically match. Okay, the registration is finished. Use green square and include one number F4.
So do you have the electromagnetic navigation in your country? This one. Yeah. Do you have optical navigation?
No, the anyone else has navigation. This country, no. Do we have any navigation? No, no Felgen. Yeah.可以，我刚才然后也把主要的步骤也给了说明。他们没有导航，他没有这样的 Felgen 导航，电磁导航。
你可以让自己一起配，基本上就差不多了。
好。
Hello everyone, I'm Dr. Zhou. So I will do the material for you. Every year I have used many kinds of navigation, like optical, like electromagnetic, even robot. For me, I will always use freehand to do this survey. But if you have navigation, you will decrease your learning curve. So I think for the past 5 years, I have done for more than 400 cases. So I like to use material. For this case, you can use olive. I think it's good. But for this one, you use material. I think is a very, very reasonable choice for this patient. I do not use Pili because there is no stenosis for this case. Only fusion is okay for this case. So later I will explore the facet joint. I will deal with much more SAG, the part of the left side of the REG. I will get much more autograft from the facet joint. And I also, from the case, I will use
Okay, the match is finished. So remove the maple. So that pad is for localizer matching. Keep the sensor, the black one, stayed in the crust. Use localizer to match like this. Yes, it works.
把这些都切一点咱们行，来播那个。So are you use this needle to check is it correct or not? Are you play the needle line to check the right? Are you using like a pen draw along the skin to check is it correct? 这是个很有美，你看有句话献给机器的不对啊？你画的这个标定点。So are we allowed to use this epinephrine to stop bleeding? Sorry. Yeah.
This step can make sure the pedicle screw direction and the depth. You can see right place on the AP and the lateral view. Put where in it.
Because we are surgeon, we can feel the bone quality. So and I guess it's good. 你没反应吗？你再打我，你说你。我听了。说一下。来，再来一个。
Next one.
三元素。For this picture, from the incision, I can guess we can use one small incision to do the one level and the teeth. I like four small incisions on one, but it depends the angle of the shape.
Yes, we need to go through the pedicle.
So also the bone quality is not so good because it's a lady. Yeah. Sure. 不要放着心，待会儿再说。继续。So using needle to plan to get a good incision, good position of the percutaneous pedicle screw. So for all the post approach, I will use this epinephrine to stop bleeding. It's very, very useful. 这个怎么说？ So also you need to find the disk space. Also find the facet joint. I should put the working channel along parallel to the disk space. So here the conical bone is very hard, so it always slipper. So here you need tenders. Always outside here.
For elderly lady, the patient has osteoporosis. At the same time, in fast joint, they have the osteophyte. So when we doing the pedicle screw, sometimes we're sleeping. So navigation is important when you use it.
Sure.
So Dr. Joe is designed incision. Actually, he just uses 2 incision. He will perform the surgery.
Not because of me, it's because of the anatomy, the angle of this one. I only like a 4 small incision, but this one I have 2, only 1. So I will use this needle to find the facet joint here, and I get a good angle. So I don't know how to place my working channel. 没有小了，它放进去。 So we always use this dilator rod to find the placenta to fill the ball. Okay. Actually. 上床，有人上床，天光到电话。
We need X-ray to confirm the location.
Maybe tomorrow I will give you my lecture about LTD. I call it SOP about the LTD. From the EP, we can the precision of the wine or the walking tube. I think it's reasonable. Not so good, but it's reasonable. 吊床，有调留意的方面都不行，叫 CT， 叫 CT， 对的。靠近，还继续向，降，继续向。
So here, X-ray is important. We should have found the right segment and the right angle. We have put the 4 wires in it and put the.
From the electro and the EP, I can make sure where is my walking tube. So I should it's parallel to this space. I think it's good. And close to the SH. 听不到？谢。这个我。
Generally speaking, the U-tube put on the lateral side of SAP. Dr. Zhou are going to perform the TLIF. TLIF means transforaminal interbody fusion.
Because from 2004, I went to the DXD. Then from 2014, 15, I went to the Institute. So I like it very much. Now I like it very much.
From the right middle part on the screen, we can see the X-ray AP and the lateral view. We have 4 good good place. Okay, first step is to make clean the soft tissues, expose the SAP. Let's see what Dr. Jones how to perform it.
So this is the ball. So if you have a good preparation, use a dilator, you should get this information very quickly. So the dilator is useful, it's powerful sometimes.
Three o'clock is cranial, 9 o'clock is caudal. And 12 o'clock is dorsal, and 6 o'clock is ventral side.
So before the surgery, we enter into OR. First, to check the CT scan. I should make sure the facet joint. What's what I should make sure the size, the shape. I should see know everything before the surgery. So during the surgery, I will not be lost.
So for the first cases today, we use transfer lamin approach for PLD. We protect the facet joint, but here we doing fusion. So expose the facet joint very clearly is needed. Dr. Zhou are going to find the landmarks in case lost during the operation. That's important.
So you should know how to use how to separate the tissue. Always separate now. So here maybe this line is SAP. Maybe I guess I first again. Here maybe that's the joint here. But this is an IEP. Maybe I check it again. Because for this patient, I don't want to do maximal decompression. Fusion is enough.
Now he's
I will use a needle to destroy the SAP lamin. Because we have navigation, if we lost when navigation, just check it again.
This looks like the gap between the IAP and SAP.
Here maybe make you make this look like, but it's always not. That means the ossified here. Oh, this may be the tape. Maybe the sensitive. Okay. So I let the assistant to hold the alternate tube to change it with the river.
This is for the river. Doctor, yeah.
So just use this one to check is it SCP the direction close to the pedicle. So I should be changing direction a bit like this way. Okay, I think it's the SCP indeed.
传理，刚才你导航的那个影像我们没有看到，没有展现出效果来啊。
他没看到导航的效果，给了呀。今天传理不会给你，导自己的地方。So from this conceptuals, we are so happy because we will never be lost because this is a navigation now. Yeah, this is the REG, this is SEG. This is outside of the SEG. Here you can see, you can check the Y. The guiding Y here. So maybe a little of bleeding, not good. Okay, further down. Further down. Further down. Further down.
Now he's reviewing part of IAP, also including SAP. Gap we can see here.
Here, the big problem is bleeding. It's actually pre-effect to the lateral side of the SCG. So you should be very careful. Here is a part of the SCG. Here, that's that's the problem. You can see below there's the problem. So the whole part of the SCG will be in the teeth. I will take all these things out. So this is the ligament level. Yeah. Okay. Here we identify the left side of the IHA because we should put the cage in the middle of the disc speech. So here is very important.这个往这边不要一样，需要这个人中枢有跑到那个腹球过去了。好，这样扶好，继续扶好。So for this interview, you have to take care of how to put the forgiveness rule in a good position. Then I use the same machine to do the filming or do the decompression. So the incision may be 4 to 6 centimeters away from the line. Here, that's the attachment about the ligament level. So, really, better enough. You can see how much the IHA cut only lateral side, not very much. But I want to get more autograph, so I need to have the IHA. Because those SCG, I'm not worried about the working nail. It I need the right one.
传理，你给大家讲一下，你有没有计划把出口根显露出来？
No, I will never for this segment. I will never explore the ability of the root because the forming is very high. And sometimes the segment building level is L5 next time. I will explore the ability of the root. For this kind of limitation, it's no use.
We to just talk about whether it's needed to explore, to expose the exiting nerve roots. And the Professor Zhou is answer that it's no need for L45 because the foramen is so big and you know there is a large room that let the cage put in it. So no need to expose the exiting nerve roots. But if the patient have the symptoms of the exiting nerve roots, they have to expose it. And if this is a segment of L5S1,
usually the external root will appear during the decompression. And this patient is a degenerative spondylosis. If it is ischemic 就是下部裂，我知道，就是这个不是那个下部裂那个单词儿。Isthmus. Yeah, the pus broken or spondylolysis. Spondylolysis. If it is a spondylolysis, the part has been broken, and the symptoms usually comes from the external root. So if you do the endothelium for spondylolysis, we usually expose the external root. Yeah.
If you want to have the ball, you should stop to believe me firstly.
传理，你再给大家讲一下你上下界的判断，就是在没有显露神经根的情况下，如何到达上支点和下支点是如何判断的？
哦，这个下支点，大家可以看到下支点已经到了位置了，这应该是。
不，你得用英语回答这样。
哦。Sorry. How to adjust the cranial or caudal side? I think for me, I will always explore the attachment of the ligament level. Here is the caudal side. We have attachment like this. Here is the middle line, but we cannot close it, but we don't need to do it. Here is the cranial side, but I think I do much more legitimately. A bit more, I think I will get the cranial side of the ligament level. 都是。After this liver, we have the attachment on the ligament level. I will show you. So the river here is not a river, you could make a special payment to make the ball separately. Okay. 这下，你看又松了。这下。 because there's ossified here, so there's multiple artery. We should never give up and stop bleeding. 这样。这样。So here, the system always want to hold your walking shoe. It's wrong. You should leave it alone to adjust the whole system in good position to take the ball out. Little. I should create attachment about the ligament to level. But the stop bleeding should be first. The big bleeding here. You can see here. Also, you can see maybe that's the extension root here.
Professor 周，请教下关节图去除的范围到什么程度就是足够的？分享一下您的经验。
I would not according to how to handle the IT. I only care about how much ball you have to explore the ligament level. I cannot give you a correct number because different size about the IT or SCT. So I only can give you the standard that you should explore the invasion, the technique about the ligament level here, like this.
This is a yellow ligament. This is attachment to the cranially. Yeah, and the external. Yes.
Yes. Here you should pay attention to the direction, the position about your walking shoe. If it's straight, you'll be wrong. You'll be entering into the outside of into the existing route. It's possible L5 or S1. It's very dangerous. Gracias.
张丽，你再给大家解释一下你向内成型的量，因为向上向下都是黄韧带支点，向内到达多少？
If you always somebody always like me, how much more I will cut? Just now I said it's different because different patients have different size on his SH or facet joint. But I think for this patient, I have cut the most part of the SH part. Only lateral, small side of the IT I cut. Another standard, I want to explore reading nerve. That's also another anatomy because the ACA is about 4 to 6 centimeters along the midline. So one can see the reading the root. I can make sure the change can be put into the base size about the big space. How this is this? Here is our怎么穿上？这么高，哎，你看这干嘛？毛松的，对吧？都不靠谱。
Professor Joe have a question, and some doctors will doing fusion first, then decompression. I notice your habit is decompression first, then fusion. Which is better?
It depends. For this patient, I will not do the decompression, only fusion. If the patient have very serious spinal stenosis, I will always do the. You can see this is reading in the root here.
Yes, we can see.
I only want you to make sure this is the standard mixtative. That's enough for this patient because I have said the incision is 4 to 6 centimeters away from the midline, not very close to the midline. For this patient, we have to see the aging root. Later I will show you. But now I should do the fusion first. Then moving for this patient.
This area is a Campbell's triangle.
Yes. Yes.
Dr. Zhou are going to cover him with the disc. We have a serious instrument help us to clean the disc high efficiency.
I will stop bleeding first. Below that's the extension of root.
Turn the tube, protect the thick and the root. You can see upright.
You can see this one?
Yes.
This is the elevation in the root. And this one is the reading in the root. So we are so lucky to see these two in the root. But it is for this patient, really no need to explore. Okay. So this is the inner scraper for this space. The size is number 8. I will show you. So you this is the number.刻在哪里？原来有刻字。
It's also like open when we performing open surgery instrument, respect to coping with disc.
I feel the interface. I feel the disc. I feel even the anterior longitudinal ligament. I will use this one to feel all this information.
明天准备个下不列的体力服做一下吧。
你做明天能做吗？现在做还吗？
应该是有的。
So before we always use tissue to insert this one into the disc space to deal with the interface, because the outer diameter of the U2 is 10.2 centimeters. So for this one, I need to insert this system into the disc space. You can see.
Yes, we can see you insert the U-tube into the disc.
So the size about 8 inch, more than 10.
It's Professor Joe's tips.
You can see I only use one equipment to deal with the interface. It's powerful.
Okay.
So here you should do this side, because we always want to make the hinge in the middle of the disc space. So here I need multiple, or you can see this as a root here. Yeah, if you can see it, you will never destroy it. You cannot see it, always you need to try it. So by always see everything first. So then all bleeding from my guideline. I know, because the ball quality is not so good. Okay, here. So we can also use the medication to guide us to get good position. Later I will show you. 现在可以用导航了，可以用吗？注意了，注意了，注意了，注意了，注意了，我来处理一下，我来处理一下。一会儿。 or you can see the more quality.
请先切到镜下的这个视频。
一会儿再切，一会儿再切，我跟你说。
It is also a good way to help us to improve our efficiency coping with the disc. Put the tube into the disc and rotate it. Now he's changing the second tube.
I have changed diameter rod to change another big one. There you go. We have two. So you can see this big one we can use the maximum size of the cage is 14. This other one we can only use the third, big size. So I will use the big one for this patient.
So put the larger tube first, then using endoscope to observe if where is the thickocyte and the root. Then you can rotate the tube to protect the thickocyte and the root. Give us safe zone when we are performing fusion.
This is the big one. You can see the tip of the walking tube. Actually, moving here. Below, that's the
镜下的视频啊，好嘞。
OK， 好的，看好，看好，掌握好，包括一个那个脚静脉的。So I will use the armature sprinkler. This one you can see to deal with the discs again.
Next step is keep going, coping with the disc. If you would like to enhance the efficiency, you can put the raspberry in it and use forceps to take out the fragment of the disc.
准备工作了。做准备12。So I will use with size but chart. I guess I will use 4T about the cage. I will use normal cage, not spinal cage.
传力这个地方，你用导航帮我们指示一下你的方向吧。
好，稍微把它速度稍微一点。好，准备导航。Just now, press my eyes. Let me show the direction about this segment. I will show you use the navigation. Now you can see the tip of the needle. I can check it's correct. Just in the middle about the cage. That's correct. I think this one I feel the anterior part of this space. Yes. You too.
Navigation is powerful for endothelium because the endothelium, the procedure of the endothelium is so many and complicated. And in order to save the time and improve the efficiency, the navigation is very important. And you can see just now that, the first X-ray during the operation appears when the full guide wire has been put in it, and the working tube have been placed in the right place. And this is the function of the navigation. So it saves a large, much time from the X-ray. And if there's no navigation, this step should be checked by the X-ray, and it will take time. When did this operation start? Around 4 o'clock?
1 hour and
It has been 1 hour and 15 minutes. Okay, all right. This including good. Yeah. Yes. So assisted by the navigation, the operation time has only 1 hour and 15 minutes. Is high efficiency. Yeah, and it's time to to deal with the interbody space, and the next step is to the bone graft input, and the last step is input the cage. Maybe this the endoscopic manipulation should be finished within 1.5 hours. Yeah.
Okay,
Professor 周请教问题，就是如何提高处理椎间隙这个椎间盘的这个效率？
First, you should explore correct disc space. The edge or posterior edge of the disc space. Then second, you should parallel your walking shoe should be parallel to the disc space. Third one, you can first use walking shoe together to expand the disc space. I think last one maybe you can use the size about the 8 screen of the top. You can use this one. Then you can use arch. I think every detail, several detail steps can improve the efficiency.
Okay.
I'll use the third one. I'll center screen. Okay, you can see this one. You can see this one.
Just now my question is how increase the efficiency when we coping with the disc.
So this one is very small, but it's helpful to deal with the detail about the end plate.
这是一个老年女性是吧？This is the old female patient, and the quality of the bone structure of the vertebral body is poor, and it's easy to be damaged of the the end plate. So supervised and monitored by the endoscopy, and it's try to protect the end plate.
So another thing, I asked Professor Wang's question, how to improve the efficiency. So the bleeding, that's very key point. It's stop bleeding. You should see everything bleeding.
Okay.
So I will show you the material longitudinally ligaments here. So why I make this size about the endoscope, we can insert the endoscope deep enough to monitor every detail about the segment, about the you can see. I will show you the room. You can see here. That's the anterior here. This is the edge of the anterior edge of the vertebral body. the beginning here. Yes, this side, also here, important. This side, parts of the entity will be destroyed, disappear. Okay, so. Okay, technically, okay, so.
你这个，你再给大家讲一讲，你这个深度是通过哪一些标志来判断它已经到达前方的纤维环？
看到了，说的。你给我那个。怎么进去？进不去。那给我是。你在这儿，你进去。别的。为什么进不去？哦，这会儿只能切换。这个小，包括是。
For the test mode.
So you are with the cage with the size is 14. The height of the cage is 14 centimeters. The length is about 22 centimeters. Millimeters. The middle. Just now, Professor was told me how to get the depth of about this disk space. I said I enter into the material part of this here. And also, just now I asked you, according to the navigation, I connect to the material part. Okay. So I use both drug with drug together. Because this patient, we only cover the left part of the eye region. And also the message is a bit smaller. Okay, good.
This step is bone graft. Otto and Ellie.
今天你们选用了一个可重开的 cage 吗？
没有。
一般的个 pick 是不是？
对对对。No cage。有听到吗？有听到吗？为什么这个名字？大概3万块。3万块。Okay, you can see the wall here. Yes. Okay. This side is very dangerous because there's a leaking root and only use a very high power on radio frequency, or you may destroy or hurt the existing root. Here is usually take care. Because the power of the radio frequency is very high now. Check the beginning. So now we can use navigation to check the rate of rotation of the cage. You can see the end of the needle passing through them. And also we can do like this or do like this to get good position. Okay, cage. That's all. Actually,
this is the second time to use the X-ray during the operation. Yeah. To check the position of the cage.
Oh,
就是不行是吧？对，我就说切 CB 刚才就没切过来。啊，好了。
往对侧走，那块。
啊？
这是。
是对面。
它就是这个，我出来这边，有那一块，你还在侧。我头上这个也把这个一下过来，直接往开在下面底座。我调 CBT， 降 CBT， 看它下边那个底座有个柱上。CBT 倾向，降，你下过一点，不要在这拖。好。So I guess the depth of the cage, because it's the main one, so I should harder. Okay. Actually, okay, a bit deep. Okay. 为什么没切过来？ 你这个 CT 可以往尾来再稍微远一点，它不在一条平行线上，一看就不可以。OK， 透。你怎么过来？开门，好像反了，反法。我们的听音，好，好。我头一听在坐在这里，我头一听你躲开点，正好目测正常，又过来，那太近了。哎，等会儿。摄像机跑了，我怎么能骚死？哎，注意，我给你。
这个地方没有，没有。对。不是这个。这是之前的。刚才又往里敲了。就最新的，直接最新的。这个是，这个像，这个差不多，这差不多。OK， 我操。So because the angle from the navigation touches, we can see the case maybe just in the middle, but this one from the entry. Why? Because the angle is we can only explore the outside of the nerve root. And that's if you want to put it just in the middle, we should let the system to be able to control the big angle. 有个正位在中间的看不见，现在这是之前的。
Not you should check the central field. 这样。
不到。
不要动。
这不是这个，这不是，这还是之前的，后面往里砸了，而且扣的像正位片。
这个正位片不是特别在中间，但是吧，也这样的。So we should have, you can see from the surgical view. If we want to decompress the nerve root, it's so easy. That's the cage. And this is the 40 size.
Yes. Okay. So we have finished put the cage, and next step is we routing putting pedicle screw, and not big. I mean it's very simple. So Dr. Zhou's suggestion. Professor Zhou， 我们现在结束这个手术，您下来讲课是吗？ Okay. Yeah, this is actually AP view and lateral view. The cage, we got a very good location. Yes, the newest one.
So another thing for this elective argument is irrigation. You never use drainage only because I will try my best to solve any bleeding. Okay, you can see the size of the incision here. very small.
赵老师可以把这个光源往旁边挪一点，就能看见切口了。
我怎么看到？这边。
哦，对，看到了，从这里看到。
对对对。
Yes.
好，可以。
Just 2 incision. We finished the fusion. Yes. Our docs applaud for your excellent surgery.
Thank you very much. Good night.
Thank you.
So, would you like to take the several minutes to discuss it? And any comments to this you have? Yes.
I wanted to ask how many days does the patient stay in the hospital after the surgery usually?
Usually 2 to 3 days. And tomorrow the patient will get up and walk around and try to feel if there are any discomforts. And the next day we'll check the X-ray. And if there's no problem, the patient will discharge. Okay. And during this operation, there's the blood loss is around 20 to 50 milliliters around. It's much less than the open surgery and much less than the mistreative. Yes, is the patient will recover very, very quickly and back to his work, his job. And so it is very popular in China for this procedure. And the shortcoming of this surgery is that the surgeon will be a little tired during the operation because only himself to do all the procedures during the operation. But it's benefit for the patient. Yeah. Any other question? No? Okay. It's a busy day, yeah? There's several lectures, that's 3 operations, and I believe that most of the people should get a lot. And it's time to relax and dinner. Yeah. Feel free. Thank you. Yeah.
Good news.